go with.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على خاتم الأنبياء والمرسلين سيدنا محمد بن عبد الله. الشيخة فاطمة بنت حشر من دلموك المختوم رئيسة مجلس إدارة جمعية سواعد الخير. الشيخ حمدان بن جمعة المختوم. الشيخ صقر بن محمد القاسمي. سعادة عوض محمد بن الشيخ مجرد رئيس فريق حالة الإمارات. الأستاذ فريق إبراهيم مؤسس ورئيس أصدقاء برئاسة الإمارات. ضيوف الشرف وضيوف المشاركين، أعضاء اللجنة الموقرون، المرضى المتحدثين والمرضى الذين يعانون من مرض الباركنسون، مقدمي الرعاية لهم في الإمارات العربية المتحدة وفي جميع أنحاء العالم، المدراء والمسؤولين، ممثلي وسائل الإعلام ووسائل التواصل الاجتماعي، أبطال أصحاب الهمم من فئة الباركنسون، السيدات والسادة.
بسم الله الرحمن الرحيم. والشيخة فاطمة بنت حاشر بن دلموك المكتوم, Chairman of the Board of the Director of the Good Arms Association, Sheikh Hamdan bin Jum'a al-Maktoum, Sheikh Sabr bin Muhammad al-Qasimi, His Excellency Awad Muhammad bin Sheikh Megrim, Head of the UAE Travelers Team, Mr. Hudayfa Ibrahim, Founder and the President of the Barkenson's Friends UAE, Guest of Honor, and the participating guests, members of the committee, talking patient and patients with Parkinson's disease in the UAE and around the world, managers and official representatives of social media, champions of Parkinson, ladies and gentlemen.
السلام عليكم ورحمة الله وبركاته. من دواعي الفخر والاعتزاز أن أرحب بكم أجمل ترحيب. أنا محدثكم أنس الحميري، ويشاركني في التقديم الإعلامي عبد الله آل علي والأستاذة ديانا فادي. ونيابة عن اللجنة المنظمة لهذه الفعالية أحييكم أطيب تحية في هذا اليوم المميز الذي يصادف اليوم العالمي للباركنسون، اللي يصادف 11/4 من عام 2021، والذي يقام هذه السنة تحت شعار ربط تجمعات الباركنسون عالميا. نحن هنا هذا اليوم مجتمعين معا لنقول أننا متحدين من أجلكم، وهذه هي المرة الأولى في التاريخ لمجتمعات الباركنسون من دول وقارات مختلفة تتواصل معا وتتشارك معا، حيث يقيمها أصدقاء باركنسون الإمارات بالتعاون مع الداعمين والشركاء هذا الملتقى للتوعية عن مرض الباركنسون على هامش اليوم العالمي الذي يصادف في 11 ابريل من كل عام، حيث يهدف هذا الملتقى إلى توعية أفراد المجتمع والأفراد والجهات المهتمة بهذا المرض لنشر الوعي ومساندة مرضى الباركنسون في المجتمع. ونتشرف اليوم بتواجد أصحاب الإرادة والإصرار والشجاعة، أبطال أصحاب الهمم من فئة مرضى الباركنسون، حيث يسعدنا حضورهم معنا، فأهلا وسهلا بكم.
Our generous presence, peace be upon you and the God mercy and blessing. AMAS, it is a matter of pride and pride to welcome you, the most beautiful welcome. I'm your speaker, Anas Alhamdi, and I participated in media presentation. Abdullah Al-Ali, and Professor Diana Fadi, and on behalf of the organization committee of this event, I salute you the best. Greetings on this special day that marks World Parkinson Day, 11th of April 2021. Held under Connecting Parkinson Gathering globally. We are here today together to say that we are all united for you. This is the first time in the history for Parkinson's communities from different countries and continents to come together and share together as Parkinson's UAE friends in collaboration with the supporters and partners holding Parkinson's awareness for the World Day of Parkinson, which falls on April 11 each year, where this forum aims to educate the community, individuals, and stakeholders interested in the disease to raise awareness and support Parkinson's patients in the community. Today, we are honored to have the people of will, determination, and courage, the heroes of Parkinson's. Thank you all.
ونود ان نشكر الشيخه فاطمه بنت حشر بن دلموك المكتوم على رعايتها الكريمه لجلسه اليوم، كما نقدم شكرنا الى ضيوف الشرف الفخريين وضيوف الشرف المشاركين، وهم سعاده عدنان النوراني، سعاده الدكتوره مريم مطر مؤسس ورئيس مجلس اداره جمعيه الامارات للامراض الجينيه، الدكتوره دانيا السمرائي المدير التنفيذي لمستشفى كينغز كوليدج لندن، الدكتورة شيخة المزروعي رئيسة مجموعة الإمارات للخلايا الجذعية، الأستاذ ناصر عبد الله سالم من بلدية دبي، الأستاذ خالد نواب رئيس مجلس إدارة فريق نبض الإمارات التطوعي، الأستاذة الابتهاج خليفة أخصائية السعادة والتفكير الإيجابي، الدكتور أمين أبو حجلة رئيس فرسان السلام، الدكتورة تغريد زهدي مؤسس ورئيس مركز أفق السلام الدولي. كما نشكر جميع شركاء النجاح والشركاء الإعلاميين لهذا الملتقى والشريك الأكاديمي لهذا الملتقى ومستشفى كينغز كوليدج لندن. وأود الآن أن أقدم جزيل الشكر والعرفان للجنة الخبراء الدوليين لعملهم وأبحاثهم العلمية حول مرض الباركنسون، وأقدم جزيل الشكر لأعضاء لجنة المرضى ممن برعوا في حياتهم المهنية على الرغم من إصابتهم بهذا المرض، وهم قدوة ملهمة لنا جميعا، وهم الأستاذ جيف شابمان، البروفيسور رونا شالام، الأستاذة فاطمة إبراهيم الحاوي، الأستاذ حذيفة إبراهيم.
We would like to thank Sheikha Fatima bint Hashir bin Dlmouk al-Maktoum for her generous care of the two-day session, and thank all our guests who are participating, His Excellency Adnan Al-Nourani, His Excellency Dr. Mariam Matar, founder and the chairman of Emarat Society Genetic Disease, Dr. Dania Al-Samarrai, Executive Director from King's College, London Hospital, Dr. Sheikha Al-Mazroui, President of the Emirates Stem Cell Group, Mr. Nasser Abdullah Salim from Dubai Municipality, Mr. Khalid Nawab, Chairman of the Emirates Pulse Volunteer Team, Professor Ibtihaj Khalifa, specialist in happiness and positive thinking. Dr. Amin Abu Hajla, president of the Knights of Peace. Dr. Zihadi Muhammad, founder and the president of Horizon International Peace Center. We also thank all success partners and media partners for this forum and the academic partner for this event, King's College London Hospital. I would like to thank the committee international experts for their efforts and for their dedication. Professor Jeff Shamben, Professor Aruna Shalam, Professor Fatima Ibrahim, Mr. Hudayfa Ibrahim.
السادة الحضور، الآن مع كلمة ترحيبية مع الأستاذ حذيفة إبراهيم، مؤسس ورئيس أصدقاء باركنسون الإمارات، فليتفضل إلقاء كلمته مشكورا. في انتظار وصول أو مداخلة الأستاذ حذيفة إبراهيم لإلقاء كلمته مشكورا.
بسم الله الرحمن الرحيم.
نعم تفضل أستاذ حذيفة، نسمعك، تفضل. We can hear you. نعتذر لكل المتابعين لوجود خلل فني بسيط. We are very sorry about this technical issue. We will solve it in a few seconds, 1 minute.
بسم الله الرحمن الرحيم. This is Hudayfa. I'm humbly honored to share a platform with our patron, His Highness, Her Excellency Sheikha Faطمة bint Dlmook, and all the other honorary guests, our fellow esteemed panelists, and everyone who has joined us today. Special thanks to Sheikh Hamdan bin Jum'a Al Maktoum, Sheikh Sagar bin Muhammad Al Qasimi, His Excellency Awad Muhammad bin Sheikh Majran, and the honorary guests, His Excellency Adnan Al Noorani, Her Excellency Dr. Maryam Matar, Dr. Dania Al Samarai, the COO of King's College Hospital, Dr. Sheikha Al Mazrou'i, Dr. Amin Bouhajla, Mr. Nasser Abdullah Salim, Mr. Khalid Nawab, and Mrs. Ibtihaj Khalifa. My whole life, I was so full of Superman energy. I was just like any other young person who wanted to enjoy life, play sports, ride horses, and give back to my community. Everything started when I was 29 years old, with stiffness in my right shoulder, followed by clawing of toes, painful cramps. After months of intense agony, unruly, unyielding pain, I was asked to see pain specialist. One fine morning, I woke up with my joints locked in, my toes clawed in. I started shuffling. My wife on one side, my kid on the other, held me and said, I remember my little one saying, Baba, I can be your walking stick. I'd seen several doctors, roamed around several medical institutions in different countries. And finally, I was told I have young onset Parkinson's disease. At that time, I was just alone, just me and my family. No matter how much I try, but I would like to say on this platform that I am indebted to my family and to my friends and to everyone who was there next to me, who looked after me, and all the doctors who were there with me and who are there with me. I would just like to share, after meeting my doctors at King's College Hospital, Professor Ray and Dr. Vinod, I felt, or I could feel, and I can still feel, the positive energy, a confidence, a glimmer that something can happen to me or my life. I remember seeing Dr. Vinod in his clinic and telling him, Doctor, you do have to wait till I finish my story. Do not interrupt me. Let me finish. I felt like before, I could be ignored, overridden, my voice, which was not heard. But I remember, and I can say on this platform, that my consultation, that particular consultation, changed my whole life. That is what gave me a new lease of life. That time I was alone. It is because of that consultation that I'm able to move around. It is because of that consultation that I'm sitting here. It is because of that consultation that each one of you is here. It is because of that consultation we are able to connect to all the Parkinson's communities across the globe. It is because of that consultation that all the Parkinson's patients in the United Arab Emirates, in the Arab world, in the Middle East, in the different continents, in different countries, in different places, everyone sitting at their home, despite of the pandemic, we are all connected, we are all united. If it was not for that consultation, nothing would have been possible. So hats off to Professor Ray, Dr. Vinod, and all the specialists, Parkinson's specialists who are there looking after all the Parkinson's patients like me. Now, let's not forget, I've been through stress, and it's not an easy thing to be in stress. I always wanted to give back to my community. We here in the United Arab Emirates, which is known as the country of happiness, the country of tolerance, we believe that happiness, prosperity, doing good, this is something that we must share. And as we all know, sharing is caring. We all care for each other in the United Arab Emirates. And I do care for each one of you, for everyone who has Parkinson's, for everyone who takes care of someone who has Parkinson's, be it a caregiver in the family, be it a medical professional, be it a doctor, be it a nurse, be it whoever you are. If you take care of someone who has Parkinson's, or you are someone who has Parkinson's, I would like to share this platform with each and every one of you equally. The reason we have this platform is to make sure the patient's voice is heard. We have this platform to make sure that each one of us, we use this platform, and I call upon all the medical or healthcare industry, everyone in the healthcare industry, to use this platform and come up and share their experiences, come up and share their research, come up, share their studies, whatever they have done in Parkinson's, and make sure all the patients of Parkinson's can cope up with life and we can make their quality of life better. This is a responsibility that I share with each and every one of you. And I'm sure each one of you is up to this responsibility. It is true I started as one, but now I have with me, I call ourselves a nuclear family. We are more than 120. And we all have Parkinson's. But Parkinson's does not stop us from anything. Parkinson's connects us to one another. Parkinson's is what makes us unite and stand next to each other. And Parkinson's is what makes us keep going. The reason why Parkinson's UAE was formed is I still have a vision that I would like to share with you. And the reason why I'm sharing is because I want to give this responsibility to each one of you. You share this responsibility with me equally. I do not want anyone to say that, Hudayfa, you have started it, you have to do it. And no, it is true, I had a vision. Now this vision, I'm putting it in front of you because I want each one of you to take this vision and carry forward. We believe in sustainability. We believe in teamwork. We believe that one person cannot do anything. It is true, I might have a vision, but to work it out, I need a team who needs to work, who has to take this up, who has to own this, and who has to keep going. My vision is first to reach, second to teach, to ensure that voice of every Parkinson's patient and caregiver is heard. This is very, very important. That time has gone when, with all due respect, I do understand that Parkinson's specialists, they have spent their whole life, they have spent their time studying, researching, and doing a lot of things for our benefit. But as a Parkinson's patient, I know what a patient requires. I know what a patient wants. I have seen my family. I know what is a suffering of a family. I know when kids look at their father or their mother and they see what this illness or what this disease does to them. So the reason behind all this is to make sure everyone's voices are heard and promoted and creating awareness or raising awareness in the community, communicating with each other, connecting, empowering patients. I would like each one of you to write this down with 3 lines under this: empowering patients. This is what I believe, and this is what my dream is, and to support carers and their loved ones. Last but not the least, I would like to say, don't let Parkinson stop you. Let's unite for Parkinson's. Thank you.
Thank you, Mr. حذيفة, for this nice word. Thank you. شكرا أستاذ حذيفة على هذه الكلمة الملهمة. للأمانة يعني لامست قلبنا في هذه الكلمات الجميلة التي تملأ الكثير من الشجاعة والقوة، ونرى في نفسك وعيونك الإصرار والإرادة والعزيمة، ونتعلم منك نحن الأسوياء الكثير من الخبرات والتجارب اللي مريت فيها. كل الشكر لك ولجميع أصدقائك من فئة باركنسون على هذا الأمل اللي تزرعوه في قلوبنا. أيضا الآن نتشرف بتواجد سعادة الدكتورة مريم مطر، مؤسسة ورئيسة مجلس إدارة جمعية الإمارات الإبراجينية، للحوار معها عن هذا الموضوع. الدكتورة مريم معنا؟
دكتورة بس لو ترفعين يدك لو معنا أمر.
طبعا الدكتورة مريم مطر هي مؤسسة ورئيسة مجلس إدارة جمعية الإمارات الإبراجينية، وكان لها دور كبير في دعم هذا المجال القطاع الصحي، وكان لها دور مجتمعي كبير جدا في التوعية لموضوع ضد الجينية. أيضا كان لها الكثير من المحاضرات والورش، كانت بالحضور الشخصي أو عن أونلاين في الفترة الماضية، وكانت ملهمة للكثير من الباحثين عن هذا العلم. ونتشرف أيضا بتواجدها كضيفة شرف في هذا اللقاء والحوار معها بعدة نقاط بما نستمد من خبراتها الكثيرة في هذا المجال. إذا الدكتورة مريم غير متواجدة أو غير جاهزة، ممكن ننتقل إلى المحاور أو الضيف اللي بعده، أستاذ حذيفة. أستاذ حذيفة ننتقل للضيف القادم.
الشيخة المزروعي، دكتورة الشيخة المزروعي.
ممتاز. طبعا أيضا يشرفنا تواجد الدكتورة الشيخة المزروعي، رئيسة مجموعة الإمارات الخلايا الجذعية. حياك الله الدكتورة معنا في هذا اللقاء.
السلام عليكم.
وعليكم السلام.
حضورنا الكريم, Your Excellencies and everyone who's attending. On behalf of myself as a President of UAE Stem Cell Group and on behalf of the Society of UAE Genetic Disease led by Her Excellency Dr. Mariam Matar, I apologize for her because she is engaged with another activity, so I'll be attending and I wish I will deliver the message of her voice to support the whole Parkinson's patients and support the Parkinson friends. It is my honor to be with you today, and I would like to thank all the members who worked on this, making it happen today. Our honored guest and the excellencies who's attending today. It's my pleasure to be part of this. And in person, I would like to thank Mr. Hudayfa for his all efforts and his very emotional talk today about being a lead of this group and this event today. We felt how he is dedicated and empathized to support all the Parkinson disease, not only in UAE, however, all the Parkinson friends, as he named his group with. As a UAE stem cell group, I believe the stem cell will be the, let's say, the future hope of the Parkinson disease. However, till today in UAE, there is no real practice on using the stem cells as a cure for the Parkinson's, but there is a lot of clinical trials who have been used to treat the patient of Parkinson using the stem cells in different places among the world. Maybe not today.
Dr. Sheikha, I have a little question about this type of disease. Dr. Sheikha, if you talk about the Parkinson friends, how you feel about this friends? They have this community, they have this activities together to show to all the world we are here, we are normal person, but we have some suffering, but still we are normal person.
Exactly. So I believe this group is very important to support the Parkinson patient all over the world, not only in the UAE. And the voice of the Parkinson patient through this group will be definitely delivered to the whole community and the whole health partners who are working on to find a solution to support those patients. For sure, there will be in the future new practices, whether using the stem cells or any upcoming new technologies to support those patients for sure. I believe this event today, especially that we are involving different partners and from different community, not only from the health perspective, but also involving the leadership and decision making in this event, is really emphasizing on the importance of supporting this group or community in the society. And we would like to say that we are all supporting the whole Parkinson patients, and we are side by side working to make this less suffer and finding a new or close solution for them.
Thank you, Dr. Sheikha, for your this word. It was amazing to feel about that, because we work together in the same place, in the same time, to help this Parkinson people to become a part with us, and we make them very happy like us. Thank you, thank you again, Dr. Sheikha, and I hope, inshallah, good life for you and for everybody. Thank you very much.
Thank you very much. Thank you.
الآن ننتقل إلى ضيفتنا القادمة الدكتورة دانيا السامرائي، المدير التنفيذي لمستشفى كينغز كوليدج لندن، فلتتفضل إلقاء كلمتها مشكورة. حياك الله دكتورة.
Hi, good afternoon, honorable guests, expert panelists, patients with Parkinson's and caregivers in the UAE and across the globe. I wish you all well on Parkinson's Day. I'm honored to be part of this symposium, and I give my heartfelt thanks to Parkinson's, Friends of Parkinson's in the UAE for making me part of the Parkinson's family and for really doing all of the work in setting up this wonderful symposium today. All of us here today are either personally impacted or we have a loved one personally affected, and it is our collective aim to bring positive change to those around us, as well as those we maybe never have met, but who we have a shared experience with across the globe. I, like many of those connecting today, am here keen to listen to the experts, to learn more about innovations in treatments, improvements in standard of care, and enhancement in the access of care. As a physician, I've seen firsthand the effects of this rare neurodegenerative condition. And as the Chief Operating Officer at King's College Hospital, London, which is in Dubai, I have heard and been touched by the life experiences of our patients treated at our hospital over the last year. I've had the opportunity to lead the visiting physician program, which is a link between King's College Hospital London in Dubai with our mothership, King's College Hospital in London, which allows us to bring world-renowned experts spearheading innovations in care to Dubai. For us, we see the visiting physician program as our way of enhancing access to care by making innovative, cutting-edge treatments available locally to patients who historically always had to travel abroad for their care. As with any chronic condition, patients' outcomes are negatively impacted when the patient does not have regular access to their physician or the physician's team for their ongoing care. Before starting the program, we knew that there were very few, if any, Parkinson's experts in the UAE, and that many patients were being managed suboptimally between their visits abroad. Given that we have a link with King's College Hospital in London, we're in a unique position to do something about this. So about 1 year ago, I met with Professor Ray Chaudhry and Dr. Vinod Mehta and discussed the great need we have in Dubai and the wider UAE to have local expert treatment. We are grateful and very appreciative that both not only were willing to make the visits, but really develop the Parkinson's service at King's Dubai from the ground up. As of today, we've treated over 170 Parkinson's patients, our advanced Parkinson's Center of Excellence, which is led by Professor Chaudhry and Dr. Mehta, both of which international leaders in their fields with immense international reputation, bringing novel device-aided infusion therapies to the entire region where there is great unmet need. While much work has already been done over the last year, we look forward to continue building on what we've established, working together with Professor Chaudhry and Dr. Mehta, as well as Friends of Parkinson's in the UAE to reach out to our community, continuing to raise awareness for this underdiagnosed and undermanaged condition. Finally, I'd like to thank AbbVie Pharma for their never-ending academic support. Thank you all again for connecting us together today. And we at King's College Hospital London and Dubai look forward to further supporting the needs of the Parkinson's community in the UAE for decades to come. Thanks a lot.
Thank you, Dr. This is what impressed, and it is good word to hear about you. Also, it was amazing to support these people again. Mr. Abdullah, you can talk now.
Thank you, Mr. Anas. كما يشرفنا تواجد الأستاذة ابتهاج خليفة سفيرة السعادة ورئيسة السلام والنوايا الحسنة. أرحب فيك الأستاذة ابتهاج.
حياكم الله ويا هلا وسهلا فيكم.
الله يحييك أستاذة ابتهاج. أستاذة ابتهاج، بما أنك سفيرة للسعادة ورئيسة للسلام والنوايا الحسنة، حابة اني اسالك سؤال في هذا الملتقى.
حياك الله.
الله يحييك. كيف ممكن نسعد مرضى باركنسون؟
في قصة تقول، يعني هو المفروض بلقي كلمة، ولكن في قصة تقول: ذهب أحد التلاميذ إلى معلمه الحكيم يشكو من كثرة همومه، فطلب منه أن يذيب ملعقة من الملح في كوب من الماء ويشربه. وعندما شرب سأله: ماذا وجدت في طعم الماء؟ فقال: كان مالحا. ثم طلبه أن يأخذ نفس المقدار ويذوبه في كوب أكبر من الماء. لما شربه سئل: ماذا وجدت؟ قال: لم أجد طعم الملح في الماء. ما المغزى من هذه القصة؟ همومنا كثيرة، ولكن عندما نخرج إلى العالم ونمد نظرنا إلى هذا الأفق الواسع سنرى همومنا أصغر بكثير مما نتصور. فنصيحة مني: اخرجوا إلى هذا العالم الواسع وستزول كل آلامكم وهمومكم التي يعني اعتبرتوها هي أكبر ما في الكون. نحن هنا من أجلكم ولأجلكم، نحن هنا لندعمكم ونساندكم. تبنوا الإيجابية كمنهج في حياتكم، انظروا دائما إلى النصف الممتلئ من الكوب وسترون الحياة جميلة بالرغم من آلامكم. الإنسان الإيجابي من أهم صفاته أنه لديه القدرة على تحمل الآلام النفسية والجسدية، فأنتم إيجابيون والإيجابية هي طريقكم. فدعوة مني بتبني الإيجابية لمنهج في حياتكم، وابدأوها بالتسامح وفتح نظركم إلى الأفق الواسع في هذه الحياة، وسترون كيف أن همومكم وآلامكم ستتلاشى في هذه الحياة وفي هذه المجتمعات.
شكرا أستاذة ابتهاج.
شكرا. يعني نحن أصدقائهم، نحن أسوياء ولكن أصدقائهم، وسنمد يد العون لهم ما استطعنا.
شكرا على هذه الكلمة الجميلة.
شكرا.
وأنا بصراحة عن نفسي أحب أشكر الأستاذة ابتهاج، وأنا أقول أن يعني ماما عودة ما شاء الله عليها دائما تبهرنا وبكلماتها الجميلة، وأنت فعلا سفيرة للسعادة مثل ما يقولون، كل الشكر لك.
سفير احنا نقول سفير الباركنسون نعتبرك يا استاذ حذيفه.
جزاك الله خير استاذ.
هذا اللقب بالفعل، يعني ان كل هالجهود اللي بذلتها لهذا الملتقى واللي نعتبره الحدث المهم والاهم في هذا العام 2021 كحدث دولي الأول من نوعه، فهو حدث نوعي بالفعل كما قال مذيعنا المتألق في البداية. فبارك الله جهودكم يا رب، وإن شاء الله دوم هذه الملتقيات الإيجابية تكون مستمرة وليست مقتصرة على مناسبات فقط، ولكن ستكون يعني ما بين فترة والثانية يكون في لقاءات احنا نقول لإضافة نوع من الإيجابية لشحن الطاقات الداخلية بالذبذبات الإيجابية التي بالفعل يحتاجها الجميع، ليس فقط المرضى، لتساعدهم على السير في هذه الحياة بكل سلاسة وبكل أريحية.
وبصراحة يعني إن شاء الله، وأنا أوعد الجميع أن الأستاذة ابتهاج اللي هي أيضا مستشارة السعادة والإيجابية لباركنسون الإمارات إن شاء الله حتكون موجودة معنا. وطبعا لا شك بأن هي لها العطاء في مجال السعادة حول العالم، وهي إن شاء الله ما بتقصر مع الجميع. فكل الشكر لك أستاذة ابتهاج.
شكرا.
قال أخوي حذيفة كل الشكر لك أستاذة ابتهاج على جهودك الجبارة.
ألف شكر لكم على الاستضافة، وبارك الله فيكم، وتمنياتنا بالتوفيق لكم إن شاء الله في هذا المؤتمر أو الملتقى الدولي، وفالكم إن شاء الله النجاح فيه.
اللهم آمين. حياك الله. ننتقل إلى الأستاذ خالد نواب، رئيس مجلس إدارة فريق نبض الإمارات التطوعي. أستاذ خالد حياك الله.
الله حيه، مرحبا والله.
الله يحييك، يا مرحبا بك أستاذ خالد. أستاذ خالد، أنا حاب أني أوجه لك سؤال، بما أنك لك في العمل التطوعي مثل ما يقولون مثل مجال ما شاء الله كبير، كيف ممكن العمل التطوعي يخدم أصدقاء باركنسون الإمارات؟
يخدمهم يسمونه بالمعنوية وزيارات للمرضى. يعني ممكن يعني المتطوعين يزورون ويعطون هدايا معنويات، يعني نرفع معنوياتهم.
مشكور أستاذ خالد، ما قصرت بعد على كلامك الجميل ومداخلتك الأروع.
الله يسلمك. بس عندي مداخلة، نقول بسم الله الرحمن الرحيم. الشيخة فاطمة بنت حشر بن دلموك الموقرة، راعي الملتقى الرسمي، ضيوف الشرف الفخريين وضيوف الشرف الأكارم، الخبراء والأطباء الدوليين، المشاركين الأعزاء، حضورنا الكريم، نلتقي معكم اليوم في الملتقى الدولي الأول للباركنسون 2021 المتزامن مع اليوم العالمي، يوم الدولي للباركنسون الذي يصادف 11 ابريل من كل عام. وإذ نحن في هذا اليوم نرفع القبعة لأصدقاء مرضى باركنسون الإمارات، لنحييهم على قوة إرادتهم وعزيمتهم في تنظيم هذا الحدث المهم والأول من نوعه، متعاونا مع فريق نبض الإمارات التطوعي. شكرا لكم من الأعماق، متمنين للملتقى بأن يحقق أهدافه المنشودة والاستفادة من كل ما سيطرح فيه. والسلام عليكم ورحمة الله وبركاته. خالد نواب، رئيس مجلس إدارة فريق نبض الإمارات التطوعي ونائب رئيس أصدقاء باركنسون للإمارات. يعطيكم العافية.
كل الشكر للأستاذ خالد نواب على هذه الكلمة الملهمة. صراحة دور كبير جدا يقوم بها الفرق التطوعية على مستوى الدولة، ونخص بالذكر فريق نبض الإمارات التطوعي اللي يقدم مجهود كبير جدا لخدمة جميع أفراد المجتمع، وأيضا بشكل خاص لأصحاب الهمم وجميع الحالات الأخرى. أيضا ننتقل الآن إلى أستاذ حذيفة إبراهيم، مؤسس ورئيس أصدقاء باركنسون الإمارات، لبدء الحلقة النقاشية. تفضل أستاذ خليفة، الميكروفون معك.
كل الشكر لك أخوي أنس. Thank you so much everyone for joining us. I would just like to share that we have right now more than 235 attendees who have joined us and would like to know more views about everyone and to present their questions to the expert panel. Before we start, I would request Mr. Jeff Chapman, who has joined us from Australia, to share a few words. Mr. Jeff Chapman is the founder and chairman of Bangra Group, a privately owned family office with extensive operations in the wealth and funds management sectors. His early career was spent in Australian manufacturing, retailing, and investment banking. Jeff and his family also founded the Benelong Foundation, which is a key component of the group. Jeff has degrees in law, accounting, and business. Jeff and his wife, Karina, lived in Bahrain for a number of years. And Jeff was also the tournament director of the Dubai Tennis Open for the first 10 years that it was staged. As part of the Australia Day 2019 honors, Jeff was appointed as a member of the Order of Australia General Division for significant service to the community through philanthropic initiatives. So Jeff, please share your thoughts on this day. Thank you.
Your Excellencies, distinguished guests, ladies and gentlemen, and those with a particular interest in Parkinson's disease. Salam alaikum. Firstly, a big thank you to the founder and president of Friends of Parkinson in the UAE for inviting me to participate in this celebration of World Parkinson's Day. As the introduction announced, my name is Jeff Chapman, and my wife Karina and I live and am speaking to you from Melbourne in Australia, where it is well past our bedtime and approaching 11 o'clock at night. My age is 73, and I have been a Parkinson's patient for approximately 8 years. I have visited and revisited many times in Dubai since my days as the tennis director of the Dubai Tennis Open. And I am delighted to support Parkinson's Day and especially support the neurological team of King's College Hospital, London, Dubai, and of Professor Ray Chowdhury and Dr. Vinod Mehta, who we have come to know and respect over the past few years. My message to you all is a simple one. Never give up and never lose hope. Hope is not political. Hope does not belong to the citizens of one country and not to another. Hope knows no religious borders. Hope is universal and is available to us all. Hope becomes purpose when it takes on an activity. So anchor your hope in a positive activity, a purpose, and fight Parkinson's. That can be by daily exercise, by walking, by taking the medications prescribed by your neurologist. And these are the measures that give me a purpose and lead me to want to win my personal battle against Parkinson's. In the introductory comments, I said I am speaking to you from Australia. There are approximately 100,000 people in Australia suffering from Parkinson's, and one person is diagnosed with Parkinson's every 40 minutes. By a process of simple arithmetic, there are probably 40,000 people in Dubai that suffer from Parkinson's, and a staggering 1 million in the Middle East that are similarly affected. Over the scheduled time of this conference for 4 hours, 60 people living in the Middle East will find out that they have Parkinson's. This is something that we fight as individuals, but we fight better collectively. My Parkinson's was first diagnosed by my doctor, who referred me to a head of neurology at one of Melbourne's best hospitals. Almost from the first consultation, my neurologist was accepting of the disease and its inevitable consequences. This was very hard to take and placed immense pressure on my family. It was also counter to everything that I'd ever done in my life prior to Parkinson's. The neurologist treated me for 3 years with standard medications, and my condition continued to decline steadily. My tremor got worse. My writing, or should I say my efforts to write, became so microscopic that not even I could read it, and my voice and ability to swallow disappeared. I shuffled. I did not walk. Karina and I decided we needed a change. As we were about to go to London, we knew through watching TV doctors that most of them came from Harley Street. So we Googled Parkinson's clinic near Harley Street, and a life-changing friendship was formed. We met Professor Ray and Dr. Mehta. It nearly didn't happen, as Dr. Mehta, in his customary form, was running about an hour and a half late. However, we determined to go ahead with the appointment, and it was the best decision that we ever made. Dr. Mehta talked to me for 5 minutes, made me walk up and down, hold out my hands, stand on one leg, and proclaimed that he could improve me by 50% in 2 weeks. We nearly fainted. The story has a happy ending. My tremor disappeared inside 3 days. My walking and talking and general coordination returned to something like normal, and I could actually write again. We have continued to consult with Dr. Mehta and his team at King's College Hospital, London, and more recently at King's College Hospital, London, Dubai. And we've done that from Australia via this magnificent new invention called Zoom. Because of COVID, these recent consultations have been conducted over the internet, and Dr. Mehta and his team continue to be very insightful and monitor any differences in behaviour patterns and the like via the internet. So we have lost no contact, and we remain deeply indebted to Dr. Mehta and Professor Chowdhury and their methods and their treatments. The layman's interpretation of the neurological miracle that Dr. Mehta and Professor Chowdhury engineered is that they concentrate the treatment to get dopamine to the brain in as quick a time and as close to its original form as possible. The team has produced and trialled a range of devices, such as a patch, which I wear on my body, a pen-like gadget to inject dopamine directly into the bloodstream, and a puffer to do it through the nasal passages. The benefit of this range of devices is that if the effectiveness of one falls off, then there is another to take its place. In concluding, I want to say I cannot speak highly enough of the work done by the medical profession at King's College Hospital, London, and King's College Hospital, London, Dubai. They are dedicated to their task, and their task is, as Professor Chowdhury has said many times, to treat the disease of Parkinson's in its current form and as it lives and breathes in a lot of us today. Research is one thing, and research is important and must go on because we must get better at what we're doing. But it is also important to treat clinically the ills that surround us today. I want to thank all those that have made it possible to appear and speak on this auspicious day. And if you are a fellow Parkinson sufferer, I wish you complete control. I'm very happy to answer questions and help other Parkinson sufferers because it assists me in my daily battle with the disease to know that I have other people in the trenches with me that I can help, and that together we can fight Parkinson's and we can never give up. I thank you, ladies and gentlemen and distinguished guests, for your time, and I support completely the views put forward by the previous speakers. I think this is a wonderful occasion and you are all to be congratulated. Shukran.
Thank you a lot, Mr. Jeff, for this. This is a nice word. Really, it was full of positive energy to all people in the world to hear you about this things you told about this type of people. Really, it was amazing, and we are very honored to be part of with us in this day. Also, I hope, inshallah, next time we play golf together in Dubai. Thank you.
That is given.
Thank you very much. It was amazing, and keep smile all the time. This is the positive energy for us.
Absolutely.
Thank you very much. كل الشكر للسيد جيف على هذه الكلمة الملهمة التي ألهمت الجميع حول العالم. أيضا ننتقل الآن إلى الدكتورة تغريد زهدي محمد، مؤسسة ورئيس مركز أفق السلام الدولي، لإلقاء كلمة بهذا الموضوع. تفضلي دكتورة تغريد.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وأصحابه أجمعين. تحية طيبة وبعد. الإخوة والأخوات الكرام، كل عام وأنتم بخير بمناسبة اقتراب شهر رمضان الفضيل، أعاده الله علينا وعليكم باليمن والبركة. لا بد لنا في بداية الحديث أن نتطرق بلمحة بسيطة عن مرض باركنسون، فهو اضطراب يصيب الجهاز العصبي ويؤثر على الحركة. تبدأ الأعراض تدريجياً، وفي بعض الأحيان تبدأ برعشة قد لا تلحظ في يد واحدة، ثم يتفاقم بمرور الوقت. بالرغم من شيوع الرعاش، فإن الاضطراب يسبب تيبساً وبطء الحركة بكثرة أيضاً. حتى نستطيع أن نكمل مشوارنا في الحياة لا بد من وجود هدف لنا، ولكن لا يمكننا الاستمرار بتحقيق هذا الهدف بدون وجود عزيمة وإصرار بداخلنا ومساعدة من الأهل والأصحاب، والأهم أن يكون نابع في داخلنا. إنما يسعى إليه الإنسان يكمن في ذاته هو. لا شيء يطلق العظمة الكاملة بداخلنا مثل الرغبة في الوصول إلى هدف منشود بالاعتماد على النفس. يقول أحد الحكماء: يجب أن تفعل ما تستطيع لأطول فترة تستطيع، وعندما تصبح لا تستطيع افعل شيئا آخر تستطيعه. يمكنك أن تتوقف بعد الوقت، ولكن لا تستسلم. عليك أن تفعل الأشياء التي تعتقد أنه ليس باستطاعتك أن تفعلها. وهنا لا بد لنا من القول أن التعاون بين الجميع ليس معيبا، بل يساعد على التآزر، فلا يمكن تحقيق ذلك إلا عندما نسمح لأنفسنا بإعطاء مساحة بأن يساعدنا ونبذل معا قصارى جهدنا، فتكون ثمرة هذا التعاون النجاح والفوز لجميع الأطراف. فالنفع يعود على جميع المتعاونين، ونشجع دائما من يتعاونون معنا مع الآخرين ويسعون لتحقيق الإنجاز المتبادل، لأن موقف المنفعة المتبادلة يؤدي إلى نتيجة إيجابية لجميع الأطراف المعنية. وبالتالي يؤدي إلى نمو المجتمع وتطويره. لذلك أقول أنتم مرضى الباركنسون ما زلتم جزءا لا يتجزأ من هذا المجتمع، بل كنتم اللبنة الأساسية وحجر الزاوية في بناء كل المجتمعات. ولولا وجودكم بيننا ما استطعنا أن نصل إلى ما وصلنا إليه من حضارة وتقدم. فمنكم الطبيب، ومنكم المهندس، ومنكم المعلم والعامل، ومنكم من كان مستعدا أن يفدي أرضه بدمه للمحافظة على تراب الوطن. تعلمنا منكم الكثير، واجبنا الآن أن نعيد لكم بعض ما قدمتوه، علما بأننا لا نستطيع أن نرد لكم إلا جزء بسيط. شكرا أستاذ حذيفة إبراهيم المؤسس لجمعية أصدقاء باركنسون الإمارات على استضافتي كضيف شرف في هذا الملتقى الجميل، وعلى ما قدمتوه من إضافة ومعلومات، وخاصة أنه ملتقى دولي فريد يتحاور به المرضى بالخبراء حول العالم، ويقام على أرض دولة الإمارات العربية المتحدة. وأخيرا وليس آخرا، اسمحوا لي أن أقول لكل شجرة عظيمة جذور راسخة في الأرض، وأنتم هذه الجذور التي تجعلنا نقف في وجه هذه العواصف. ولكل سفينة تجوب المحيطات والبحار ربان، وأنتم ربان سفينتنا، أنتم الماضي، أنتم الحاضر والمستقبل معا. والسلام عليكم ورحمة الله وبركاته. معكم دكتورة تغريد زهدي محمد، رئيس مركز أفق السلام الدولي وناشط إنساني. وشكرا.
شكرا دكتورة تغريد على هذه الكلمات من القلب، ألهمتينا بهذه الكلمات الجميلة. أيضا دوركم أنتم في مركز أفق السلام الدولي في دعم جميع المبادرات المجتمعية.
إن شاء الله.
تغريد about this good. الآن ننتقل إلى الأستاذ اللي هو جوكر أو الجندي المجهول في هذا المكان، ودائما الكل سعيد بمشاهدة ابتسامته. أستاذ حذيفة إبراهيم، نرجع لك مرة ثانية لاستكمال حلقات النقاشية. تفضل أستاذ حذيفة.
كل الشكر لك أخوي أنس وللدكتورة تغريد على كلماتها الملهمة والمحفزة للجميع. I would like to inform everyone that we have right now more than 230 participants and attendees with us. And from the time that we had announced about the event, we have a lot of questions that have come to us for the expert panel and the patient panel. So I think time has come that we move to the main part of today's event. But of course, before we do that, we have with us just a second. But before we do that, I would like to invite the Pro Vice Chancellor of SRM University, who is part of our patients panel, and that is Professor Lieutenant Colonel Arunachalam Ravikumar. He is the Pro Vice Chancellor, Medical and Health Sciences, SRM Institute of Science and Technology. He's a member Board of Management Planning and Monitoring Board, Academic Council, member Board of Postgraduate Studies, ENT, and several other boards. I would like to invite Professor to share a few words and share his thoughts for 5 minutes. So, Professor, can you please share your thoughts before we move on to the questions that we have received?
Thank you very much. I am indeed thankful to the Parkinson's UAE for inviting me to speak today. Your Excellencies, members of the expert panel, ladies and gentlemen, greetings from Chennai, India. And I, on behalf of my faculty and members of the university acknowledge this opportunity to share my experience as a Parkinson patient. I've heard a wonderful commentary by the previous panelists, and I just wonder how many more thousands of people are having similar experiences. I am a doctor trained in ear, nose, and throat specialty, and also I have trained in microsurgery of the ear and cochlear implantation. I was working as a professor and doing fairly well in my profession. I mean, it all hit me like a tsunami. I was just short of my 60th birthday, to be exact, exactly 7 years back, April of 2014, when I noticed the tremors in my left hand. Being a micro ear surgeon, I found it difficult to cope with it. The neurologist, within the first and second consultation, an eminent neurologist in my city, diagnosed me with this condition and asked me to take medication and exercise, and said that you can perform everything, but there will come a time in about 5 years or so when you will start noticing that things are not exactly what you want to do. You will find it difficult. And then I did my own little research, and I found that this was a story with many patients, and I was totally, thoroughly disillusioned. And especially when I realized that I would probably be a person who will not be able to perform my favorite task of doing surgeries. 3 months of this depression, and then I said, let me fight it out. As a student, as a youngster, I was a sportsman and a paratrooper and a skydiver. So I said, like everything else, I have to fight it out. And then I went on and on, but the disease was progressing. And very soon I discovered, like my previous panelists have said, my signature was altering, my speech was stuttering, my gait was shuffling, and my ability to perform long surgeries was coming down. It was providence, and it was really a godsend when one of my childhood friends discovered me in this state, and he brought me to Dr. Mehta, who happened to visit my city. And that consultation, as some of you have said, really, really changed my life. 1.5 hours of consultation, precise. He reduced so many medications, he added a few, and told me what to do. To make things less monotonous and short, I will just read out what I wrote to Dr. Mehta 8 months after I met him. This is in October of 2019. A note to express my profound gratitude and convey sincere thanks for what you have done in controlling my Parkinson's disease. I came to you about 8 months ago after having consulted and being treated by 3 eminent neurologists. I came with no hope as my condition was worsening rapidly, even though I was taking 11 tablets round the clock. After a thorough clinical assessment, you changed my medication while questioning the rationale of many medicines that I had been prescribed earlier and was taking regularly. Besides, you were rational in your approach and took pains to explain everything to me and treated me like a professional colleague. Though skeptical in the beginning, I developed a deep respect for you and your expertise in this field. After 8 months of your treatment, I am a changed man, leading my life with a new vigor and confidence. My depression has nearly vanished. I am able to do many things now that I was struggling to perform earlier. That is, buttoning my shirt sleeves, wearing a necktie. I am walking with confidence and speaking with authority, courageously, all thanks to you and your team. I wish that God grants you many more years to continue your service and expertise to rescue many patients across the globe. Now, this is 2019, and today we see that we are gathered from across the globe to join hands in fighting this disease. And I still remember what I normally project at the end of my lectures, that is, never give up. And we would never give up. As the first panelist said, it is devastating when it happens to you, but if you have the courage and the willpower and people like Dr. Ray Chowdhury and Vinod Mehta, who could actually do research and give us the hope that this is a controllable disease and this is not something to be shy of or to be afraid of, we can still perform. And after 7 years of this disorder in me, I am performing far better than what I used to do earlier on. We would have probably millions of people in India with a population of 1.3 billion who need help in this. So I have decided that in my university, we would do whatever research is required and partner with King's College London and try to take things forward in this part of the world. And we are definitely proactive in this field. I wish to thank one and all for giving me the opportunity, and we would hope more and more such wonders happen across the globe. Thank you very much.
Thank you so much, Professor. Now, before we move on, I would like to introduce the expert panel. Now, all the names in the expert panel, they are the world-renowned Parkinson's specialists. Their name does not require any introduction. We start with the chair of the expert panel, which is Professor Ray Chowdhury. He is the Professor of Neurology Movement Disorders at King's College Hospital and King's College London, and the Medical Director of the Parkinson's Foundation International Center of Excellence at King's College. He's the chairman of the Member and Public Relations Committee of the Movement Disorder Society and chairman of the MDS Non-Motor Study Group and member MDS Education Committee. We also have with us on the expert panel, Professor Perodin from Sweden. Professor Perodin finished medical school at the Uppsala University in Sweden in the year 1982. He became specialist in neurology in 1993 at the Lund University, Sweden, and got his first professorship at the Medical School Hanover, Germany in 1998. Odin is now Professor of Neurology and Head of the Division of Neurology at Lund University, Sweden. He has focused his interest on movement disorders since 1987, and his main research areas concern continuous We have, we were. As the chairman of, as the chairperson of the expert panel, we have Professor Ray. And we have also Professor Perodin from Sweden. And we have Professor Christian Falep from Romania. Professor Falep is the head of the Department of Neurology, County Clinic Hospital from Brussels, and is the Associate Professor of Neurology at the Transylvania University from Brussels, Romania. He received his medical degree from the University of Medicine and Pharmacy. He holds a one-year fellowship of the European Neurological Society in Movement Disorders and Sleep Medicine at the Hospital Clinic University of Barcelona, Spain, Chair of Education Committee of the International Parkinson and Movement Disorder Society European Section, and many other committees. And we have with us Dr. Vinod Mehta from the United Kingdom. He's the consultant interventional neurologist and movement disorders, dystonia, Parkinson specialist. He trained at King's College Hospital, London, and conducted his higher specialist training in neurology and movement disorders at Imperial College London, University College London, and Queen's Care Hospitals in London. He's a member of the Association of British Neurologists, an Australian and New Zealand Association of Neurologists. He was awarded his doctorate for research on the pathophysiology of and treatment options for disabling non-motor symptoms of fatigue and sleep in patients with Parkinson's disease in collaboration with King's and Imperial College London. He was a recipient of the 2016 ABN Australasian Fellowship. And we have with us also Professor Rupam Burgohain from India. He is the president of the Movement Disorders Society of India, Professor of Neurology at Nizam's Institute of Medical Sciences, Hyderabad, with an experience in neurology and especially movement disorders over 2 decades. He is dedicated to the care of patients with expertise in movement disorders, especially dystonia, Parkinson's disease, and mentorship of his students. He started the DBS program in NIMS with more than 550 surgeries conducted under his stewardship since 2000. And we have with us Dr. Mish'al Abu Al-Milh from Kuwait, Head of Neurology Division and Movement Disorders Unit, Al-Aden Hospital, Kuwait. He's the Director of the Movement Disorders Unit, Al-Aden Hospital, Director of Neurology, Movement Disorders, Botulinum Toxin, Dystonia and Neuro-Ophthalmology Clinics at Al-Aden Hospital, Kuwait, Director of Neurology Residency Program, Kuwait, and Chairman of the Neurology Postgraduate Training Committee, Vice Chair of the International Parkinson's Disease and Movement Disorders Middle East Working Group Steering Committee, who graduated from the Medical College, Faculty of Medicine, Kuwait, University of Kuwait. Moving on to the patients panel, we have Mr. Jeff Chapman, we have Professor Lieutenant Colonel Arunachalam Ravikumar, and we have Ms. Fatima Ibrahim Hawi, and your host Hudayfa. We move on now. First of all, I would like to ask the chair of professional of the expert panel to take up from here. Professor Ray, are you with us? Professor Ray?
Hello?
Yes, Professor.
I'm sorry, I could not speak because I was not being allowed to be unmuted, but I wonder if you can hear me now.
We can hear you. We can
Oh,
hear
lovely.
you.
Thank you very much. Well, I think it's really a great honor for me to be asked to chair this. And I'm speaking to you from London, England, on behalf of the expert panel that you've already introduced, which is a stellar group of people in terms of clinical service delivery and academia in Parkinson's across Europe, across Israel, India, Middle East. And I just wanted to start off just by thanking a lot of people for this initiative. The first and foremost is, of course, the Parkinson's UAE, and you heard a moving contribution from Huzaifa on this. And I think it's really something that touches not just people with Parkinson's and their carers, but also us working in the field. I'd like to also send my grateful thanks to and appreciation to Her Highness Fatima Maktoum, His Highness Hamdin Maktoum, and the Prime Minister of Dubai, Al Maktoum, as well as support from Dani Al Smari on behalf of the King's College Hospital in Dubai. And all the panelists who have given up their time. And Sunday, I understand Sunday is not a holiday in the Middle East, but for us in the UK, it's a day off, and the panelists have taken time to speak to us at this time. And of course, central to all of this is Dr. Vinod Mehta, who has done such sterling work in setting up this service at Dubai. And really, the most important contribution to this is what the people with Parkinson's from the area are telling us. I just wanted to say a few quick words about Parkinson itself. Dr. James Parkinson described this condition 204 years back from the city in London. And in this 204 years, you might ask, what have we actually learned? Well, I think what we now know that we are dealing with a condition which is an epidemic within a pandemic. The pandemic is COVID-19 and the epidemic is Parkinson. Parkinson's numbers are projected to double, and it's already happening, and the impact will be felt very widely in countries like in countries within the UAE and the Middle East, and India, and various other African continent. And the reason for this is people will probably are living longer, and we're also diagnosing people with Parkinson's at a much younger age. So we'd like to have some discussion on that front. And while there is a doom and gloom front, because at this moment in time, we do not have neuroprotection or neurorestoration that can arrest my condition as it is for many years to come. On the other hand, on the optimistic angle, we do have absolutely fantastic advances on device-aided therapies, which Dr. Mehta is spearheading in Dubai, in King's College Hospital, Dubai, but also other forms, new molecules, new therapies, exercise, complementary therapies. And there's much to look forward to, which our panelists will tell us. So I think with those words, I think I would like to just open up the questions, and I presume either you pass on the questions or to me, or we will do it whichever way that suits us. But maybe I would first pose a few questions to our panelists, and you'd hear the pearls of wisdom from them. Maybe I'd first ask my colleague and good friend for many, many years, Professor Per Rodin. Professor Rodin, would you comment on what might be, in your view, the key unmet needs in Parkinson's?
Thank you, Ray. Do you hear me?
Yes.
Good. Meeting. It's really a pleasure to listen and to be here.
Your voice is a bit soft, Per. I don't know whether you need to come nearer to the mic.
unmet needs, I would say, number one is, of course, neuroprotection, and the possibility to slow down or stop the disease process is really what we all look very much forward to, and what will be a game changer, I think. But for developing this, we need also other things. I think we need better animal models and models of Parkinson, models that more closely mimic the real disease than what we have presently. We probably also need a better understanding on how the disease progresses and develops and spreads in the nervous system. I think we also will need to come forward on these better biomarkers to be able to detect and diagnose Parkinson correctly as early as possible, and to be able to measure disease progression. But we also need better treatments for the symptoms, further improved methods to manage motor symptoms, motor fluctuations, and we, of course, got now in the last decades the pump-based therapies that you mentioned, deep brain stimulation, and these have been very big steps forward in the treatment of the disease. But these methods can probably further be refined. Maybe we'll also see completely new technology. Stem cell transplantation was mentioned. That is something that we work with here in Lund, among other things. We also, of course, better treatments for non-motor symptoms. That's still an important area of development in the symptomatic therapy. And then concerning care, I think we all realize that a doctor is not enough to take care of a Parkinson patient. I think that we need much more capacity for multidisciplinary care. Parkinson nurses, specialized personnel for physiotherapy, occupational therapy, speech therapy, psychiatry, sexology, social problems, etc. We need much more resources here, not least also because, as you said, we are seeing an increasing number of patients. And we should never forget to also take care of the caregivers. The caregivers are extremely important persons for the patients, and they have a lot to do and need support. I think that an unmet need is also the last years of the disease, the end of the life. I think that is the focus of a European project that several of us are involved in now, to do the last years of the disease more human and better quality of life, to see to that the patient still can keep contact with the neurology and also palliative care. Many patients now, when they reach the end of the disease, they have lost contact with neurology when they need it as most, and that is something that we must change. So that were some things that I think we should do during the coming years. Thank you, Ray.
Professor.
Thank you very much for that very nice summary of what might be a huge area of unmet needs, as you've beautifully illustrated. I want to ask Professor Christian Falupekurario, also another very good friend of mine and eminent researcher and clinician. I know there will be lots of questions for the panel, and Dr. Mehta has already alerted me to this, but I wanted to ask you, Christian, what is your view on what might be if I'm diagnosed to have Parkinson's, and if I went to you as you're my doctor, what sort of treatment options can I expect?
Thank you very much, Professor Chaudhuri, and hello to everybody. It's really my great pleasure to be with you in these online settings, and I would like to thank to Friends of Parkinson UAE for this kind invitation for organizing committee. I would like to thank to Her Excellence Fatima Maktoum, His Highness Hamdi Maktoum, Excellencies, ladies and gentlemen. Really, it's a great pleasure and honor. And as we just heard, this is a fantastic day of 11 April when we are celebrating the connection of Parkinson communities, not just in Arab countries, which is a wonderful countries, connecting Australia, We've heard fantastic views connecting Europe, connecting United States. And I would like to say hello to the expert panel and to the patients, and please allow me, Excellencies, the answer to Professor Chaudhuri to these questions. It's very easy question, but meantime, it's very complex, because when a patient is coming to us, we need to offer the diagnosis and offer as well the treatment possibilities. So medication can be used to improve the main symptoms of Parkinson's disease, and we need to explain to the patients exactly what the sort of symptoms they have. Not all medication available are useful for everyone, and the short and long-term effects of each are different. Basically, to answer to your questions, there are three main types of medication that we are commonly used. Levodopa, which was first described, dopamine agonists, monoamine oxidase B inhibitors.
Sorry, Professor, really sorry to interrupt, but just to let you know, because we have a lot of questions that we have received, I will just forward these questions to the chair, and Professor Ray is going to present it to the, he's going to redirect them to the expert panel. The first question is from a patient who says, I'm 57 years old. I underwent a tremor operation 4 years ago. Thanks to God, my problem is only stiffness and immobility. I still have severe stiffness, freezing, and falling over. My doctors say battery is still working, but at the same time on 15 tablets. I don't have quality of life. Is there any treatment for stiffness? And will it help the speed of movement in terms of walking? And is gel treatment good for me? And can I start it?
Hi, sorry, I had another problem with the muting. So perhaps I can ask Professor Rodin, would you like to take that question?
Yeah, well, one can to the treatment of the tremor. I guess that you got VIM stimulation then against the tremor, and then you did not have effect on the slowness and stiffness so much. But you can compensate that, of course, with medication. And the first thing is then to find out if you can get better with a rather high dose of L-Dopa. And if that is possible, one can then compose a treatment, oral treatment with tablets and maybe patches that will help you to good movement. If in spite of this, there would be fluctuations and difficulties with off periods with slowness and stiffness during the day, one can also, of course, think in direction if pump-based therapy could be in pump. What we reach with the pumps is then mainly that we get a more constant effect compared to peroral therapy. So there are many possibilities, and you should have good contact with a good neurologist, and it will probably, things will become better.
Thank you, Per. Thank you. I hope that was very useful. So perhaps maybe Jose for the next question.
Yes. The next question, Professor, it says, does night work or working at night affect the medication and durability of my on and off state?
Excellent question. So this is about if you're working at night, does it affect the way your medication is going to be working and so on? So important issue about nighttime and Parkinson's. So may I put this question to my colleague, Christian Falud-Pecorario?
Thank you very much. So I think this is a practical, real question because it's dealing with the nighttime problems when we are sleeping. So as a human beings, we are during the daytime and we are sleeping in the night. And somebody who is going to work at night is changing his behavior. So in other words, he's working at night and is sleeping during the daytime. Basically, the pharmacology, so meaning the drugs availability in the blood would be the same, and the pharmacodynamics. But meantime, these changes of daytime and nighttime would be influencing just over the sleep. So answering the drugs would be quite the same. The quantity of the drugs would be the same, but it's much depending of the time that the patient is going to bed in the morning.
Many thanks, Christian. And I think it's very important, isn't it, that we treat Parkinson as a 24-hour condition, not, we often as clinicians forget the nighttime, and it's crucially important that we focus on nighttime management as well as daytime, because Parkinson's is active whether it's day or night. I think that's the really important point you make. Thank you very much. Next question, please, Saifa, for the panel.
Sure. We have a question which says, the patient says his left side is affected. He has many problems, including slow movement, severe pain, which originates from the shoulder, fingers, and feet, and sometimes in the button area. He was diagnosed with Parkinson's 6 years ago. What would the expert panel advise? The patient says he's currently taking levodopa, carbidopa 8 times.
Excellent. Very good question again. Perhaps I can ask our colleague, Dr. Michel, please. Would you like to comment on this?
Yes, hi. Thank you for the intervention, and it's my pleasure to attend the World Parkinson's Day. And much thanks for the Parkinson UAE friends for the invitation and the excellency. So regarding the medications, if you're taking left-sided stiffness and pain and cramps, so that's all fit with the unilateral symptoms and with some dystonia. So the question is here: are we dealing with a continuous symptoms or just a fluctuation? For example, since you're taking 8 tablets, so are you taking 1 tablet every 4 hourly or 2 tablets every 4? So it depends on the levodopa carbidopa dose. And so are we dealing with a wearing off, or you have an early morning dystonia, or it's the continuous issue? Because if you have an issue, for example, your symptoms of pain and stiffness is occurring like 1 hour or 30 minutes or 2 hours prior to the next or second or third to the fourth dose, then you have other options as I do to increase the frequency from, like, for example, 6 hours to 4 hours or 3 hours, keep the same dose, or of course, bumping the levodopa carbidopa dose. But I usually go with, of course, if you're taking like tablets, is change the frequency rather than bump up the dose just to avoid the dyskinesias. And of course, if you don't want to change the levodopa carbidopa dosing, you can add the dopamine agonist such as the rotigotine patch, which is the best option, which I use for my patients, which can help smooth out the issues. And of course, you can use the other medications as MAB inhibitors, rasagiline, or sulfonamide. So we have a lot of options. And sometimes if you don't like, some patients will not like to use all medications, for example, and you're looking for something to like smooth up the situation, you can add entacapone 200, like with each levodopa carbidopa dose, or change it to a Stalevo, which is the levodopa carbidopa entacapone. Now, since you're on 8 tablets, and if there's any fluctuations and you're having many offs, and I think this is, and you have more than now 6 years, I think this is the best time for your neurologist to think about like a device-aided therapies, and that will smoothen out your situation and pain and issues. So I just like give you a one-shot summary of what's going on, but that's in a nutshell.
Dr. Michel, many thanks. Your background is making me very jealous. Wonderful sea and the palm trees waving in the wind. Excellent. Dr. Michel, what would you, do you have any experience of opicapone? Because you raised the issue about COMT inhibition.
Yes, actually, opicapone is the 50 milligram once daily dose. Okay, for the compliance would be an excellent share. But of course, in the UAE and in Kuwait, we don't have it. Yeah.
Right.
Yeah, exactly.
Right. Okay. Thank you so much. Okay, Huzaifa. So here we go on to the next question from you, sir.
Sure, Professor. Now, this patient says she is 61 years old from Chennai. Her problem is stuttering, and she finds it difficult to complete any topic that she starts. Her speech is merged without understanding. She also suffers from changes in the facial muscles as well as the fingers of the hand. What might help?
Perhaps I can have a go at this. I mean, you've raised a very important problem of stutter or stammer. We know that the process of Parkinson itself can aggravate this. And because Parkinson itself leads to a speech issue we call palilalia, where, you know, in its extreme form, it becomes very difficult to understand. Now, medication-wise, the dopamine medication that we have, unfortunately, they're not that terribly helpful. However, broadly, if you have your mobility state or movement problem well covered, they will help the speech because speech is a motor function. So again, to get from your local specialist the right amount of dopaminergic medication, whether you're receiving Syndopa or a dopamine agonist, is really, really very important. Sometimes this problem with the speech develops when the condition is in an off state. If that is the case, it needs to be soothed out by more longer acting dopaminergic drugs. But crucially here, important would be to see a specialist speech and language therapist, because there are many techniques that are now available. And one of them is, for instance, Lee Silverman voice therapy, which actually strengthens your voice, but can also indirectly help with the stuttering, but also other devices and other techniques that are available, which are not necessarily medication-based, which can also be very useful. So you need a dual approach, one through the medication, augmenting the medication that we already have. The second is getting in through a specialist, speech and language specialist. And I hope that will help. Perhaps we can move to the next one.
Okay, we have a question that we have received as video. I will just ask to play it. And this question is for you, Professor. And this is in Arabic, and we will translate it for you.
السلام عليكم. أنا هنادي. زوجي مصاب بمرض الباركنسون من 11 سنة. قبل 7 شهور، هو تقريبا عمره 68 سنة. قبل 7 شهور انصاب بكوفيد 19 وتأثرت الذاكرة عنده. فهل الكوفيد له علاقة بضعف الذاكرة أو لا؟ وهل سؤالي الثاني، هل استمراريته في أخذ أدوية الباركنسون إن شاء الله هالشيء بيحسن من قوة الذاكرة عنده، ولا بتتم الذاكرة عنده مثل ما هي حين ضعيفة وساعات ينسى؟ وإذا هي الأدوية بتنفعه، كم المدة اللي يحتاجها المخ أو الذاكرة إنها ترجع مثل ما كانت؟ وجزاكم الله خير.
The question is from Mrs. Hanadi on behalf of her husband. He's 60 years old, and he had Parkinson since 11 years ago. She said that her husband, he's got infected with COVID-19 7 months ago, and after that it's affecting on his memorize ability. He cannot remember the things good. And she said, is COVID is relating to this? And she's asking, he's still taking the Parkinson's medications. Is the Parkinson medication is going to help him to retrieve back his memory? and how long does it take for the treatment?
Okay, I think I might take this one. It's an excellent question from Mrs. Shnazi. So I would like to suggest, and I would like to see what the other panelists think as well. So what we think now, what has emerged over the last 3 or 4 months, that there is existence of a condition we call long COVID, or the new name for it is PASC. Long COVID is defined as symptoms that emerge after 3 months after somebody has had a COVID infection. And this can go on for a while. And the impact of long COVID in Parkinson has not been known, but we've very recently published a paper from our group along with several other colleagues in a journal called The Movement Disorders, where we for the first time defined that in a group of people who had COVID and who had developed long COVID, they all suffered from very severe fatigue, which is tiredness, not sleepiness, but tiredness, a sense of exhaustion, along with memory issues, and along with unmasking of things such as insomnia, anxiety, and pain. So I think what you're describing really fits in with this concept that your husband is showing the signs of long COVID syndrome in Parkinson's. Now, how much there will be improvement is unclear, but I'm optimistic that over time this will gradually get better. And while dopaminergic drugs are important for movement, they may not necessarily help with the memory-related issues that you're describing. The two things that might be really useful here is to ensure that he's having good quality sleep, because sleep has an effect on memory. Second, perhaps discuss with your own neurologist to get some formal memory testing, what we call neuropsychometry. And third, if required, use memory-enhancing drugs that we use in Parkinson's with memory problems, such as rivastigmine, which can be available both as tablet and as a patch, perhaps for a short duration of time. And fourth is to have some memory-enhancing exercises. They are also available. And with this, I'm optimistic that there will be a recovery, but I think this is very much related to the so-called long COVID syndrome, which we are realizing and seeing. Not just in anybody with Parkinson's, anybody who've had COVID-19, but also people with Parkinson's. So those would be my views. I'd just like to ask the panel if anybody else has a view. I understand we haven't asked Rupam Bogohain, my colleague from India, who's a premier neurologist and movement disorder specialist, internationally known. Perhaps any comments from you, Rupam, then Per and Christian and Vinod, would you like to comment?
I think Rupam is talking, so...
I got it, sorry. I was on mute. Thank you, Ray, for the question. First of all, I'd like to thank the Friends for Parkinson's UAE group and your excellencies for inviting me to speak. What I do agree is that it must have had an impact on this, but I'm not sure as to how close was this patient to Parkinson's disease with dementia. Mild involvement must be there from long-standing Parkinson's, and whether this has actually tipped the balance. So maybe we can monitor a bit, reduce the anticholinergics and the dopaminergic agonists, and try some of the anticholinesterase, see whether we can do better with that for this Parkinson's disease-related dementia that she's complaining about. Forgetfulness, difficulty, the rest of the motoric deficits, I would agree with you. Fatigue from long COVID, with as well as worsening of the Parkinson's, because quite a lot of comorbid conditions can worsen Parkinson's disease. Any comorbid condition can worsen the Parkinson's disease. So I think the rest I do agree with you, Ray.
Many thanks, Rupam, for that. Any comments from Per, Christian, Tol, and Vinod?
Yeah, Professor, actually, I want to share a couple of patients I've seen, in Dubai, especially with the vascular history, vascular risk factors, they're having like diabetes, long-standing diabetes or hypertension, extensive small vessel disease, and where they're poorly controlled, like vascular risk factors like smoking, and these type of patients, especially left untreated during the COVID time. I've seen few patients actually although they're on like dopamine agonists, and they are not being given the treatment during the time on the ICU being treated. These type of patients I came across with worsening of significant memory. So to my knowledge, I don't think that anything acute COVID positive or anything like any other infections, acutely can cause memory related issues. So perhaps I will ask Christian to share his views as well.
Thank you, Vinod. Thank you, Ray. We just followed some patients with PD that were infected by COVID. And honestly, we didn't know exactly how to deal with, because it's a new disease, this COVID. And exactly as mentioned, Vinod, we need to learn as well. And we were lucky enough that Ray put together this experience of other groups, and he led these international groups in UK, Italy, Mexico, Thailand, and Romania. And we just shared the experience that we had. A part of what Ray highlighted, I would just add some comments that it's different approach. So, for instance, in the first period of time, and I understood that the patient had 8 months ago the infection. So, in some countries, the people with even asymptomatic or mild symptoms at the beginning of the pandemic were admitted to the hospital. And afterwards, in other countries, just the medium and severe patients were admitted. What we learned, that severity of the COVID-19, as indicated by the history of hospitalization, did not seem to be the condition sine qua non for development of a post-COVID-19 syndrome in PD patients. So in other words, if a patient was admitted, Parkinson's disease patient was admitted to hospital with a medium or severe form of COVID-19, it doesn't mean that he or she will develop a long, severe COVID-19. Meanwhile, we need to take into account that prolonged lockdown were everywhere, and some countries were even now severe lockdown, and this increased the anxiety and depression of the patients. And meantime is reduced access to the healthcare and rehabilitation interventions. And this post-COVID-19 clinical manifestation may result from the combination of new symptoms, exactly as Ray highlighted and Vinod, as well as the lockdown-related augmentation of pre-existing PD-related features, because we know that the PD symptoms are a big spectrum, especially of the non-motor symptoms, and for the memory complaints and memory problems were augmented by this lockdown and banned to go out for many patients. Thank you very much for raising this important question and issue.
Thank you very much. I think that was really useful. Thank you. Thank you all. So Zefa, shall we go on to the next point?
Which says, has there been any progress regarding treatment in the Arab world? And how effective is it? My father now, 67 years old, taking too many tablets. Doctors here say surgery, surgery, surgery. And the question says, is there any other thing other than surgery? Is it possible to reduce the dose of Cinemat?
Okay, so that's a really important question. And again, I think I'd welcome the panel's view. Perhaps Dr. Michel, would you like to take this one?
Sorry, I didn't get the question. The sound was interrupted. So,
Zaifa, can you just repeat the question again? It's about other options after surgery, isn't it?
I'll do that, yes. It says the patient is now 67 years old, taking too many tablets. Doctors here in the Arab world say surgery, surgery, and surgery. And they want to know, is there anything other than surgery? And is there any possibility to reduce the dose of cinnamon?
Okay,
and the question also says, is there any progress regarding treatment in the Arab world?
Okay, sure, great. Excellent question. Yeah. So, first of all, we need to know why to reduce the cinnamon. What are we dealing with here? Are we dealing with the levodopa-induced dyskinesia, or are we dealing with fluctuation like an off symptoms? This is very important. And, in the Arab world, the device-aided therapy, it depends from one country to another. Like, for example, in Kuwait, we have DBS, we have the duodopa, and we have the apomorphine pump. We have all the device-aided therapy. So when I see a patient with a huge amount of medications, we need to know what are we dealing with here. Are we dealing with the dyskinesia part or the off symptoms? Now, when they meant by surgery, maybe they were dealing with DBS. So we need to put the options on the table, because since your father is having a lot of medications, and we know in the Arab world, they have diabetes, hypertension, so many things going on. So they want to reduce the medication. Yes, we can reduce the medication, but on the expense of the other things, like they will get more stiffness, more pain, more cramps. So I don't recommend reducing the symptoms, reducing the levodopa carbidopa dose if you're dealing with an off, not like the dyskinesia. So your father needs the device-aided therapies. Okay, so we have the deep brain stimulation, we have the duodopa, we have the apomorphine pump. So what I do with my patients actually is like a shared decision making, SDM, and this is the new thing. In the MS world, they're doing it, and I think in Parkinson's we need to do it, except for DBS, which has a strict criteria for it. So we need to explain for the patients what we have in the market and what's the pros and cons of each modality. So I expose my patient to DBS, and I expose them to the duodopa, and expose them to the apomorphine pump. And for example, they're saying, well, for DBS, we are managing resisting tremor, dyskinesia, and they're just focusing on DBS. But let me say something. I have a lot of patients who are tremor resistant and dyskinetic, improved remarkably on duodopa, magic, even a week after. And I have a great videos about this. Even with apomorphine pump, it's a market. So we need to open the windows here and just avoid to be biasing on one modality. So in a nutshell, yes, you can reduce the medication, but on a device-aided therapy. We cannot go ahead and reduce the levodopa carbidopa dose because we'll tip you on the stiffness and pain, unless you are talking about dyskinesia and your father doesn't want to go to any surgeries. Then we can manage or reduce the levodopa carbidopa dose with the expense of raising the dopamine agonist accordingly, or we have so many options for that. I hope I answered the question there for that. Thank you.
Dr. Michel, thank you. That was very eloquent. Perhaps I can also bring in Professor Udin here, because I'm aware that Professor Udin led a massive study across Europe called the Navigate PD study, which is addressing exactly what you're saying, Dr. Michel, is that people, particularly people with Parkinson's, should be aware now that there is not just one mode of therapy. Deep brain stimulation is a very effective treatment in correctly selected patients, but every patient, when there is availability, should be given the options of infusion therapies as well. As you've quite beautifully pointed out, apomorphine, levodopa infusion can all have effects similar to deep brain stimulation without requiring 2 holes in the head and a brain surgery. So perhaps Professor Udin, would you like to make a comment? And after that also Dr. Mehta, because I'm aware that he's also doing quite a lot of infusion therapy work.
Yes, like you say, Ray, I think it's a very good idea to go to a doctor or a center where they offer not only surgery, but also the pump therapies. And the choice between the different device-aided therapies is a difficult one. and but should be done very carefully so that each patient gets the therapy that fits him or her best. And actually, in Sweden, we have national guidelines from the government on Parkinson treatment, and those guidelines say that the decision about advanced therapy should be taken by a person and in a therapies. So choice and objective advice to the patient about the therapy.
Excellent, thank you, Per. Vinod, any comments from you, Dr. Mehta?
You're muted.
Thanks, Prof. Chaudhary. Yeah, I think the patient selection is the paramount for the success of any device-aided therapy. Say, for example, I choose my patients very carefully. Although we have being worked with Ray for many years and having Center of Excellence at King's, and choosing which device-aided therapy is actually the patient selection is a paramount for the outcomes. See, especially at our center, I say, for example, if a young patient with a refractory tremor, unilateral tremor, maybe I consider surgery initially, but not for elderly patients or other patients. So I don't think DBS surgery is for all stages and all ages of Parkinson's patients. So say, for example, I'll give you small example scenarios, Prof. Chaudhary, if you allow me kindly. Say, for example, if you have a 60-year-old gentleman who is badly reacted or not responded to agonist, I won't choose apomorphine. And, I would select for, levodopa infusion. Or there is a young patient, very well done, excellent, on agonists, maybe, or, to delay the dopamine infusion, I prefer subcutaneous apomorphine. But again, young patients with a unilateral refractory tremor, or those type of patients, I choose DBS. I'm sure Rupam here, World Authority in DBS, might would like to add a few words, whether he accept or refute what I said.
Yeah, thank you, Vinod. No, the question is what you actually expect to achieve for
quality of life, Rupam.
Yeah, that I agree with you. But see, the main problem is the off phase. The off phase is an issue which doesn't improve with other therapies as much as it does with DBS. The off scores of the UPDRS I'm talking about specifically. Now, while when we did the safinamide trial, just for a digression, I'm digressing a bit, but when we did the safinamide trial, what you need to realize is that you can actually reduce the dose of syndopa or levodopa when you add safinamide, but you must realize that initially safinamide will increase the tremor, the dyskinesia, and you need to taper the dose after when you reach 100 milligrams per day, and then reduce the dose of syndopa. That works very good for control of dyskinesias. It reduces dose of this thing, and quite a few of the patients have a very marked increase in on time. It doesn't work for everybody, but the patients it works. The initial dyskinesia is actually controlled by reducing the dose of syndopa later on. So you must wait for that and do that if it is required. Because if you say that you add safinamide initially, the dyskinesias come up, and you discontinue the safinamide, then you are losing the efficacy of safinamide for your armamentarium. Secondly, as far as DBS is concerned, I've been a very strong votary because we've been seeing these patients for 20 years. And what you do see, which is not very well documented in literature, is that the initial decline post-surgery gets better, about 70% or so. And you get a reduction in drugs and all the side effects are seen. Side effects come down. What you actually see is the decline subsequently, which is not very well documented. It does appear to be a little less than what you see in patients who have not undergone the surgery. Now, whether this is something that Pierre Odin would agree with or not, I would like his view on that. Because you've been following up these patients for, say, 15, 20 years. And it's quite impressive as to how long they get a functional life out of this. Now, I'd like to see the same thing for the apomorphine pump and for long-standing patients with levodopa pump. I really don't know how long that can be done. That's the only point I have, Ray. Not that we do the apomorphine pump here. We don't do the levodopa yet because it's very expensive, and we've not been able to afford that here. But efficacy is good. I've seen a couple of Vinod's patients, and it's been very impressive.
See, Rupam, I totally agree, Rupam. I've seen amazing, drastic results in your clinics with DBS surgery. But, you know, having said that, say, for example, in India, you only have an option of DBS. But whereas in Europe, we have options, you know, we are, and see, what the question to Dr. Michal that, you know, gentlemen asked, surgery. That's something actually echoing here, Rupam, where they have other options in, you know, in Middle East, in Dubai. So they have an option of subcutaneous apomorphine. There's a option of intrajejunal levodopa infusion. So only this sort of, you know, the surgery, that's what I also experienced here. Perhaps Per and Christian can add, say that whether it's a need for any guidelines or anything like that may be useful.
If I can come in there before, just very quickly, very good comments, both from Vinod and Rupam. There is evidence now, the EuroInf2 study compared DBS with apomorphine and levodopa infusion therapy. Per is a co-author in that paper. And it clearly shows that the motor and the non-motor efficacy of apomorphine is duodopa is absolutely same as DBS. So this idea that the DBS gives you better UPDRS scores, yes, it might do in some, but you can get that with apomorphine and levodopa infusion as well. As clearly documented in that. It's an open label because there are 3 different strategies, but the evidence is there. And in fact, the non-motor benefits of apomorphine and duodopa are actually much better than DBS. So you have to, if you think about the whole picture, and then you think about the side effects of DBS, not just physical, but the mental side effects that we now know, you need to really cautiously think about it. And I'll echo what Vinod is saying, that if you have a system which is very oriented towards DBS, then you tend to have unconscious bias for the clinicians to go towards DBS and then think, oh, well, the infusion therapies may not work as well, but that's not actually true at all. The evidence.
We have a lot of patients who are scared of surgery. It's not that we can do brain surgery.
So I think if you have the availability.
Option, and we do the pump for them. It's not that we are not doing the pump, apomorphine pump, that is. We definitely do it, and we do get good results. It's not that we are not doing it. But how long is the follow-up is what I was concerned about.
Yeah, I mean, the DBS data is available. Per will probably speak to that from Uppsala from the 90s. So, you know, I have got patients with DBS now coming up to 14 years with, you know, they're still active. And so with duodopa. So perhaps I can open it up to Per and Christian for your views here.
You want to comment on the long-term effect of the pumps? Yeah. For duodopa, there is now a publication from Fernandez, which he has followed patients that participated in the large duodopa trials, and he has a mean follow-up time of 4 years. And up to 4 years, the effect is unchanged. It is exactly as much reduction of off time as it was in the beginning. So the effect seems to be long-term. And for how long the patients will be treated, one can say that for duodopa, reason for stopping duodopa is that you die of other reasons. And the mean treatment time, according to, there are several studies on this now in the literature, is about 8 years. For apomorphine, it seems to be a bit shorter treatment time, mean treatment time, and maybe apomorphine can more often be seen as a temporary solution. But there are certainly some apomorphine patients that also have the treatment for very long. The longest duodopa experienced patient, you know, a single patient that I have seen is 15 years.
Really useful. Christian, any comments from you, sir?
Yeah, it is a very good question and very nice discussions. And I think we share the same advanced PD patients that are having more options. And we need to discuss with them exactly what we could offer. And especially we mentioned the quality of life, which is different in each country and for each patient. For some patients, the tremor is important. For other patients, the slowness is important. And it's very important what they would like to reach after the treatment. If I saw the patients of Vinod recently and impressed by duodopa. And obviously, the DBS patients are impressive. So everybody have experience, and I think the main thing is to discuss with the patients exactly what the treatment would have, and they discuss the side effects, the long term, and because some patients are disappointed because they are not having did not stop the tremor, did not stop other things. And we need to explain to them that no treatment will cure unfortunately, no cure the disease. We will improve many things, the motor symptoms, some non-motor symptoms, but unfortunately we could not cure the disease. And as Per mentioned very nicely, and huge experience, this kind of treatments that are available, and Ray, regarding some non-motor symptoms on long terms are quite the same, and it's much depending of the experience of the center, I would like to say. Thank you very much.
Thank you. Thank you so much, Professor.
So thank you. That was a smattering of comments, which I think will help, I'm sure, everybody. I think one last point I'd like to make is age. You know, there is another vast majority of patients we often see with the need for device-aided therapy might be in the 70s, 75, and many of these patients, DBS probably will not be possible. So what do we do? And device-aided therapy remains the main option.
No, I agree with that.
Infusion therapies.
But it is really a problem that depending on which hospital you go to, that will decide which advanced therapy that you get. That is a problem in many countries, and also in Sweden. We have been talking about this for many years, that it should be not depend on hospital, but it still depends much on hospital when we compare how much we do of the different treatments. Yes. So one has to work on.
Professors, I would just like to add that right now we're getting a lot of questions, and I think we will just have to limit them to 4. If you don't mind, I'll just come up with the question that we have right now.
Sure.
My name is Carmen from Romania, living and working in Dubai. Dubai is my home away from home. I would like to ask whether you have same treatments, which is dopamine gel, available in Romania.
So may I pass this question to the King of Movement Disorders from Romania, who's in the panel? It's Christian Falupecurario. Christian, over to you.
Yeah, thank you very much. So yeah, it's about duodopa. Yes, it's available. So there are many centers that are doing duodopa. So the patient could be referred, and happily we could take care, or other centers as well. Yeah. Thank you.
Many thanks. Thank you very much, Christian, for that. Shall we go to the next question, Seifa?
Sure, Professor. Now, I think time has come to also include the patient panel as well.
Mm-hmm.
There's a gentleman with the name of Mohammed Hassan. He's a software consultant who works in Perth, Australia. His father has Parkinson's disease and lives in Sharjah. I think Mr. Jeff Chapman can share his thoughts on this. He wants to know, what advice would you give to him? He's always depressed with no motivation at all. Your advice is highly appreciated. A big hope for my father. And he also requests to translate in Arabic so his father can understand, and he thanks Parkinson's UAE for everything that is being done.
Yep. I just missed the last part of the question, Zeifa. Can you just repeat that for me again, please? Hello?
Can you hear me?
I can hear you now, yes.
Okay.
I couldn't hear the last part of the question, Zaifa.
Okay, the question is for Jeff Chapman, saying,
okay, thank you.
He wants to know what advice would Jeff give to his father, because his father is always depressed with no motivation at all. And he says Jeff's advice will be highly appreciated because it's a big hope for his father.
If Jeff is on the line, Jeff, over to you.
Yes, I am here, Professor. Look, if his father is depressed in Perth, that is a very sad case, because Perth is one of the world's most beautiful cities. Unfortunately, in Australia, whilst you gentlemen on the medical panel have shown how easy it is to share information, it doesn't seem that the new methods of treating Parkinson's filters out to the rest of the world as quickly as it should. And so we found in our exploration of trying to find good neurological treatment in Australia that very few people actually treated the disease, or as you gentlemen refer to it, the symptoms of the disease. And when you're 60 or 70 years old, you have a primary interest in stopping the progression of the symptoms of the disease. You have a secondary interest, and you love the cure for Parkinson's to be found, but your primary interest is in being treated for the disease. And that is very hard to find in Australia. There is a lot of research being done. There's research being done into sleep disorders and all manner of aspects of Parkinson's. But it was not until we came into contact with Ray Chowdhury and Vinod Mehta that we actually found someone who was treating the disease and could make and have an immediate effect on my condition and the pressure that was being felt in my family. So my advice to this gentleman's father in Perth is to not give up hope and to see. I'd be very happy through Dr. Mehta to contact his father in Perth, speak to him personally, advise him of my case and my circumstances personally, and offer him what assistance I could. And perhaps that might ease his depression and give him some hope for the future, because as I said in my presentation, hope is a prelude to purpose, and purpose is important, is vital in life, especially when you're battling against Parkinson's. So, Professor Ray, is that an adequate answer to a medical question? I'm not used to getting those.
You give a fantastic answer, much better than many medical people will. And I really like your analogy of, or your description of hope. Isn't that wonderful to hear from you? Thank you very much for those comments, Jeff. Much appreciated. Thank you. Zaif,
Yes.
Where do we go?
This question is to Professor Rupam, I guess. It says, my name is the patient's name is Naidu from Hyderabad, India, and says, nice to see Professor Rupam and the panel. Brain surgery has worked well for a few years and is now, the patient is now getting full body stiffness and shaking. Tablets are not working so well, and wants to know, are there any new medicines for him or her?
I don't know what your current medications are. So, and when did you last see the neurologist? I'm also in Hyderabad, but that's not the point. Who's the current treating doctor is the question. Number one. Number two, we need to check your battery. The most important status is that the status of your battery is fine. If the battery is not working well, you will go down dramatically. In fact, they become totally confined to bed and, you know, very morbid. You put the battery on and they get a full life back. It's quite amazing as to how the difference DBS makes as far as without the battery. I suppose that happens to the pump-related infusion of jejunal dopa, as well as it happens to apomorphine. I haven't seen that much, so I can't tell you, but that is one major thing that you need to look at. Secondly, you need to look at the programming parameters. There is some need to increase the current as you go. You need to see that you are programmed adequately and properly. Those are two things. As far as new drugs are concerned, we do have safinamide come into India, and that's available. Normally, it is added on to. That's funny because we did the trials for the international markets. It first came in Europe, then it came in America, then it finally came to India. We have Sun making it in India at a very nominal price, which is very good. The other drugs are not. Opicapone is still not available in India. So we do add safinamide to most of the patients nowadays and reduce the other drugs to see whether it helps. And I do follow a lot of Dr. Ray Chaudhry's and Meta's strategy of stepping up the drugs very high. We don't have the patch available easily yet. It was available at one point of time, but still it was withdrawn from the market subsequently, as far as that goes. That's about all as far as the drugs are concerned.
I think it's worth also noting, Rupam, and I think perhaps Per and Christian and Vinod might, that we do have patients where DBS has been done initially, and then they've gone on to very successfully be treated with duodopa or apomorphine. So that does prolong the whole efficacy period for quite a long time. I've had several patients like that. And similarly, the other way around as well. I've had duodopa patients who have developed dyskinesia, who's then gone on to have DBS. So the two can also be delivered. Of course, it's expensive, but it does work.
I fully agree. We have the same experience in not so few patients.
We are fortunate that while it's expensive, it's not extremely expensive DBS in India compared to other countries. I don't know why. Maybe the surgery costs are much less here. So the whole thing can be done around 10,000 to 15,000 US dollars, which is a fraction of the cost which is there available in the rest of the world. So maybe we are a lot less expensive as far as the physicians are concerned.
Very good point. Excellent. Shall we move on to the next point?
Yeah, sure. This patient is from Pakistan, who says, I have a question for Dr. Vinod regarding her father. Her name is Aisha. Her father is suffering with Parkinson since the last 6 years, although the disease is progressing but controllable. What worries her father is the excessive drooling, and says that they change the towels at least 15 towels every day.
Not able to hear that. I'm not able to hear. Is it muted? Is it?
No, I can hear you.
Oh, excellent. Looks like that question's right to me, Prof. Chaudhry. Is it okay if I take it?
Yeah, please do.
Thank you. See, this is not only a problem with patients with Parkinson's. I actually see these patients in motor neuron disease. I've seen the patients with multiple sclerosis. A lot of patients like with the neurodegenerative problems, this excessive salivation, drooling is one of the most common symptom where they have affecting their quality of life. So I know there is no time. I just want to cut it short. Perhaps I'll leave that to panel as well. So we do see a lot of patients, irrespective of stage of the disease, duration of the disease. This drooling and hypersalivation is one of the important non-motor symptoms. And I have to share with you and pride myself to work with Ray. We actually developed this service at King's College Hospital, London, since last few years, where we actually started chemo denervation, ultrasound guided injections. However, that should be the last resort. The first, I would suggest non-pharmacological options. Like, you know, I always say that ask the patients to have a nice oral hygiene or technique, chewing gums can help. The next step, if it doesn't work, is to go on to a pharmacological options like a spray, or I personally prefer like ipratropium, antimuscarinic sublingual can work for some patients. The next step is a atropine drops as well. 1 or 2 drops under the tongue can help rather than taking glycopyrronium. I'm not a great fan of glycopyrronium because it can cause mucus plugs. Then if not option C, then I go on to the chemo denervation, and it works extremely well. Option A, B, and C for drooling. And I've seen, you know, Rupam's clinics or, you know, high-tech botulinum injections to vocal cords, to salivary glands. Amazing. I would say that would be the definitive treatment, and it works really well. I would like the panel to take take it if they want to comment, perhaps Rupam or Christian, Per, or Dr. Michal, any thoughts?
Yes, I can add regarding salarias, hypersalivation. Actually, my approach in those patients is actually, of course, in non-pharmacological way, but usually that fails. Medications. So, as you know, we need to avoid as much as we can anticholinergics in Parkinson's disease, especially the elderly, because of the cognitive issues and the hallucinations. But in my experience, actually, there's one drug which actually been missed by a lot of neurologists, and which they get scared about it. But I use it for my patients. It's called amantadine. Amantadine is an excellent drug. It has so many pros in that medication, actually. And, you know, it has a weak anticholinergic effect, and actually it can help salaria. So I used a lot of my patients, and usually I go with 100 milligram, 1 tablet a day in the morning. Plus, when you bump up the levodopa carbidopa and the other medication, that will help also cause dryness of the mouth. So when I see them the next visit, they told me, wow, that's great when I added the amantadine. And just avoid the trihexyphenidyl. I don't use that medication because of side effect profile. But amantadine has a great effect. I don't use it on high dose, especially in the elderly, because it can cause sometimes cognitive issues and hallucinations. But 100 milligram once daily dose, that may be sufficient. Now, the second option is sometimes a patient, what I use, which I found it helpful, is using scopolamine patch. And actually, I found remarkable results with this patch. And I have one patient who actually declined it because of mild hallucinations, but the other ones were actually happy and they had a remarkable improvement after the patch. And then my end, of course, I go with the botulinum toxin, other parts glands, the glands, the chemodenervation. So this is how we go with the and sometimes I don't use the antidepressant, like for example, the amitriptyline. I use it more in the in ALS patients, but usually in Parkinson's disease, I try to avoid as much as we can those medication. Yeah.
I think basically all of us follow the same and save chemo. Basically, Botox injections are quite easy to give. You don't even need much. So those landmarks, the superficial landmarks are sufficient enough to get you there. And the results are very good. At least 50% reduction you can get with once in every 3 months. And that usually suffices for the patient. In fact, some of them have dryness of the mouth and you need to tailor it a bit. But that's about it.
I agree with everybody, and maybe one can add that a first step, as always, with non-motor symptoms, it can also be that you see that one optimizes the dopaminergic treatment.
Yes, I think I agree with all of the comments as made by the panel. it's a stepwise process, isn't it? I think, as Vinod said initially, look at the head posture, ice in the mouth, chewing gum, and then you go on. I've found that the injections are really very effective. For us in the UK, only Xeomin, which is one of the forms of botulinum toxin type A, is licensed for use for drilling. I'm not sure what's the situation in Middle East or in Asia and in parts in Sweden, Romania. I think it's also Xeomin probably. And it works very well.
Thank you, Professor. Thank you, doctors. Before we move on,
so I think we're heading towards the last couple of questions, right?
You're absolutely right. We have right now, we'll just take 2 more questions. We have more than 40 questions, but we will just be taking the last 2. But before we do that, we have more than 250 attendees, many of them patients, caregivers still with us. This is the spirit of Parkinson's.
Fantastic.
This is what I would say a dream come true, which is connecting Parkinson's communities across the globe. Now, going back to the questions, there's a patient by the name of Yusuf, says, like Hudayfa, he was diagnosed with Parkinson's disease at the age of 30. I was told to have a condition called restless legs. And he heard King's College London is famous for this. And a lot of research has been done at King's College. He says, now, did I get restless legs syndrome because of my Parkinson's? He says, my doctor says same treatment works for both conditions, which is Sinemet, but it doesn't actually make his condition better. It makes restless legs syndrome worse. He says, what treatment would you recommend? Over to you, Mr. Chair.
Okay, hi, thank you for that question. Very, very important question. We can spend all day discussing this. You're very lucky that we have 2 members in the panel, Professor Odin and myself, who wrote the first book about restless leg syndrome going back in the early 2000s with another colleague called Professor Olano. Now, restless leg syndrome is a very common condition. It's 10 times commoner than Parkinson's and occurs in general population. It has a specific diagnostic criteria. We do know it occurs in Parkinson's with twice as much frequency, but it is very unlikely that you've got the RLS because of the Parkinson's. But the one thing that's important to note that the restless legs in Parkinson's might be a little different from the restless legs we see normally in general population. Levodopa for the treatment of restless leg syndrome is useful, but it causes high rates of what we call augmentation, where the drug might actually bring on more restless legs at night. Therefore, what is very important is long-acting treatment. And in many cases in Parkinson's restless legs, we would use a skin patch through the night, very low dose, such as retigatin patch. Or you might need to think about that group of treatment or non-dopaminergic treatments such as drugs such as gabapentin or pregabalin and drugs such as that. So levodopa alone may not be sufficient to manage the restless legs itself, but the etiology and the occurrence is very complex. I don't know whether Per would like to comment, and Christian, because I know both of you have worked with RLS.
No, I fully agree with you. We use rotigotine and also pregabalin in that situation. And in some patients, it might even be necessary to have stronger drugs, opioids and so on. But generally, a good effect of long-acting dopaminergic drugs.
Christian, any comments from you? Thank you, Per.
I fully agree. This is a topic which is sometimes controversial, because it seems that there are two diseases or one disease that is coming after or included in others, or less is included in the PD. Both of them responding to levodopa. I fully agree with you. Right now, it's not very clear the etiology and exactly how to deal with, but I fully agree with your plan of treatment. So dopaminergic treatment itself, levodopa is not offering the relief, and dopamine agonism, transdermal rotigotine, which is offering the same 24 hours pharmacokinetics. So the level of the drugs is the same for 24 hours, could offer a good option for this. And pregabalin as alpha-2 delta ligand is an option. And obviously, if we are going forward, if not responding to this treatment, the opioids are an option. And I've just read about this. If even opioids are not effective, I don't have experience in this, but DBS, it seems to be an option. And obviously, as Ray mentioned, documentation is an issue, and sometimes it's difficult to deal with the patients with the Parkinson's disease that have on and off periods, and they have stiffness, they have fluctuations, motor and non-motor, and how exactly to find all the criteria of the RLS. And obviously, if we are using dopamine agonists, we need to take into account that there are a percentage of the impulse control disorders, and it's much depending, obviously, a part of the impulse control disorders and augmentation problem, the age of the patient.
One can maybe add also that in severe cases, also pump-based therapies could be usable for this.
Exactly.
Absolutely.
Thank you.
Absolutely. In fact, apomorphine works brilliantly for restless-leg syndrome at night, as well. I'm pretty sure levodopa infusion will as well, actually. So yes. Excellent. I hope that answered. Dr. Mehta, do you have any comments? Dr. Michelle?
I think, no comment. We'll go on to the next question, Professor Chaudhary. Excellent discussion, I have to say that. I'm enjoying, I'm learning from the experts.
Thank you. Thank you. You're very, very modest. Zaifa, perhaps we go to the final question.
Professor, we have a question that we cannot ignore. It's from Brazil. And the question says, my problems are poor handwriting. Do I have Parkinson's?
May I ask who will take this question? Perhaps Rupam?
Yeah, I'll take that question. Because I have been doing a lot of work with writer's cramp too. So I have more than 1,000 odd patients treated over the last 25 years with Botox. And I've been looking at the mirror movements to differentiate between the two. The hand, it's not that I have not made that mistake. Call somebody writer's cramp and turned out to be Parkinson's 10 years later. Yes, I have. That has happened. But it's usually the difference in size. Writer's cramp patients, the writing tends to become bigger, more disorganized, more uncontrolled. And you have got sectorial, you draw a spiral, and only a certain sector will show the tremor more often. So that helps to differentiate. What shows up classically is that the mirror movements is very easily seen in patients with writer's cramps. And in fact, this helps to differentiate. This has, of course, just now been published by Kailash and all, which is that basically they were looking at primary writing tremor, so-called primary writing tremor, now ought to be dystonia. But all these years, we've been looking at these patients with writing problems. They always have mirror movements. So it was never ever very clear as to why they were called primary writing tremor. So by and large, most of the patients who have only writing problems have writer's cramp. Some of them can have other forms of dystonia. Micrographia is the classic finding in patients with Parkinson's disease. Now that's totally different from what you see in patients with writer's cramp, where you see larger sizes, you see the handwriting becoming disorganized, and you see that after the first few lines, they become disorganized. So if you look at the handwriting, it's very easy to make out. If you see them writing, it's very easy to make the diagnosis of whether it's writer's cramp or whether it is Parkinson's disease. I hope that answers the question.
Yes, I think I'm pretty sure it was very, very nicely addressed. And with your experience, are there any other comments on this at all from anybody?
I just want to add one thing, Professor Chaudhary. I have to say, I've seen few patients actually being misdiagnosed with like a unilateral writer's cramp. I can see that, you know, Rupam is the old authority in that one, as maybe stiffness, troy, levodopa. So I've seen in my experience. So maybe this is a very good question too for the panel discussion. If anyone has problem in writing, you know, we need to see your movement disorder specialist. Please don't delay or you know, waiting. Sometimes it can come as you know, unilateral stiffness, sometimes misdiagnosed as writer's cramp as well sometimes. So maybe perhaps what you think, a question to the panel, a young patient coming up with unilateral stiffness, perhaps starting distally, then going to proximally, the role of DAT scan before we start considering any botulinum or, you know, or rather than delaying the diagnosis. I want to the expert panel to, you know, give your expert views on it.
That's a very good point to make, Dr. Mehta. I think one of your questions was, do I have Parkinson's? I think it's important to also look at the quality of your writing as it becomes shorter or smaller. If it gets smaller, that is a term we sometimes use for a thing called micrographia. And that might be actually a sign of Parkinson's and might be worth discussing with your doctor. And often what we ask for is a handwriting record of your record of writing maybe 5 years back. Compare that to what it is now. Micrographia was actually originally described by Dr. Parkinson himself in 1817. So perhaps I could ask my other esteemed panel colleagues for their comments. Christian, Bear, any comments, Dr. Michel?
Yeah, I just agree. This is I agree with all of you with this topic, which is very important, and obviously is important to distinguish and to follow up the patient, I think, and not to have the diagnosis which the patient would like to have, obviously, and we as well. But perhaps in order to avoid, at least is my experience, in order to avoid in such cases, a little bit more difficult cases, I am follow up with the patient and I am asking to come again more often. This is my experience in order to avoid a mistake, not to say this is a diagnosis or this is a diagnosis. This is what I am doing. And to talk with the patient all the time and during other appointments as well. Yeah. Because I was impressed exactly by how was addressed the meeting with Dr. Binod with Professor Chaudhary regarding the diagnosis of Parkinson's disease and the treatment. So the patients are trusting the doctors, and we trust the patient in, and we are communicated. We are part of the same game. So we trust each other and we try to help each other with everything. Thank you.
Thank you very much for those comments. Thank you. I'll pass it on back to Mr. Huzaifa and also to Dr. Mehta.
Before we go ahead with a question, I think I have a video. I think I will share the video first, and then we take the last question.
الأخ عبد المنعم عندي بس فيديو أبغى أشغله I think we'll take the question.
Hello.
Can you hear me?
Yeah, I can.
Okay. The question says, Dear Dr. Ravi Kumar, I'm from India. After seeing your photo, I was delighted to share with you I'm one of your students studying third-year medicine at SRM University. You're an inspiration for all of us and generations. My mom has Parkinson's disease. We're from Rajasthan. We all like to hear a few words from you. How you cope up with this condition. Thanks to Parkinson's UAE for this noble deed. You're doing a great job. Please let us know how can we be part of this.
This will go to Rupam?
No, this is for the patients panel, which is for Professor Ravi Kumar.
Professor Kumar, please.
Can I hear me?
Yes,
can you hear
we
me?
can. Yes, we can.
Yes, we can.
First of all, thank you. I think this student of mine who's asking this question on behalf of his mother, I think I hurriedly told my experience. The most important thing is mental strength. I think if you think you can cope with it and you can have the resolve not to give up, that's important. It's not easy. It hits everybody and they do get depressed when it happens. But then when you keep trying hard enough and you get the early signs of some control over your disease, that acts like a tonic. Not only the medication, but overall, one has to be strong enough to accept certain things and keep on trying. Simple things, wearing on your trousers, wearing on your socks, and putting on your sleeves. These small improvements happen and that adds to your confidence level. Secondly, interacting with fellow patients, as it's happening now. We see a number of people who are been affected by this problem and how they have overcome it. This is actually the right way to build up confidence. So I think if your mother could see the recorded video of this program, it would actually help. Thirdly, we should not think that just Syndopa or one Pacitane is enough for this treatment. There are a number of more options which have come up. I was put on this patch and that did wonders to me. And there are so many other gadgets which have come up, and research is really adding a lot of inputs which are helping people. And lastly, the most important thing is, I think the treatment has to be individualized to each patient. And that is what is important. And we must always not lose sight of the fact that the disease is progressing. It's a progressive disease, degenerative disease. So periodically we have to titrate the medication or alter the treatment depending on how the progress is going on and if there are any new symptoms coming up, how to control it. So it's a comprehensive treatment, as it was pointed out by Dr. Ray. It's not only the doctor, neurologist, the physiotherapist, the occupational therapist, speech therapist, swallowing therapist, as well as psychologists sometimes. They all should be involved at some point of time. And family support, because the family also suffers a lot along with the patient. And we all succeeded because of our family support, which has also played a big role. This is my advice to you. And if you need any further information, I'm available to share with you in SRM. Thank you very much.
Now, I think there is one last question, which I would like to present it to the expert panel. What is your advice for young onset Parkinson's disease, for patients who have young onset Parkinson's disease?
Okay, young onset Parkinson's disease, what might be the options? Perhaps I could go to Professor Odin and Professor Faluk Picarariov. For Professor Odin first.
No, you're muted. You're muted. So you're muted.
Sorry, it's a big theme. You have to be especially careful, of course, with high doses of L-DOPA. So treatment-wise, it will probably still be so that we will start with a combination of drugs using dopamine agonists and MAO-B inhibitors and maybe amantadine and L-DOPA in relatively small doses. And this is, of course, because of the long-term risk for motor fluctuations and dyskinesias. And then otherwise, life as possible with normal activities and try to enjoy the life. And but also to inform ourselves at a relatively early stage of the disease about the advanced therapies to get used to the thought of advanced therapy, because many of these patients will come to a situation where the symptomatology cannot be handled in a good way with standard oral treatment, but DBS or pump treatments might become of interest within not so many years. And it's good to get used to that, I think, from the beginning.
Any other comments? Christian?
I think this is an extremely important question, and I think the whole panel would share the experience, the cultural experience, and how to deal with. In my experience, I am talking much with the patient regarding the treatment. I fully agree with Per, the options. How to start the treatment and how to avoid different side effects and how to explain. And meanwhile, I try to explain as much as possible the complexity of the PD. So I try to explain the motor and especially the non-motor symptoms and to encourage the patients regarding the future. And I advise them to spend the normal life, the normal daily activity life, the normal professional life as much as they can. So I think this is what I'm doing, and I'm follow up them with shorter distances, so meaning that I have more appointments with them in order to explain, because they started earlier the Parkinson's disease and they need to have more knowledge regarding these complex diseases. Thank you very much for this complex question.
Thank you. Any other comments from anybody? Vinod, would you like to comment? Rupam, would you like to comment? Dr. Michelle?
Yeah, I would. I do advise them, if they have less motoric impairment, to take a vigorous exercise, really sweat it out. The evidence for this may be very thin as of now, but it does seem to help in keeping them mobile for a longer period. What would you say to this? You are the expert, so you should tell us. Right?
Well, I agree. I think there is quite compelling evidence of exercise in early stage of Parkinson's, and in fact, so much so that several, governments are now doing formal exercise trials to see if this could be incorporated into the pathway of care for Parkinson's. But the exercise needs to be very graded and personalized, isn't it? Not everybody can do all sorts of exercise, so it needs to be what is good for one person. And as you said, there are some platforms available like the PD Warrior platform. You can do an online course with them, and they do exercise programming, which is suitable, bespoke to your needs. But it's not just physical exercise. I also would insist or emphasize the issue of mental exercise, keeping yourself mentally supple through simple, playing chess or cards or bridge or doing crossword puzzle, because, there is some evidence to suggest that also prevents some of the cognitive issues type things. So exercise is critically important, particularly in the early stages. Absolutely, I agree.
I will add one. Yeah, sorry.
More so for the younger patients, I've heard. Go ahead.
Yeah, sorry. Yeah, great. So regarding management of young PDs, so the strategy is as usually what we see, like most of the neurologists will go using dopamine agonists, MALB inhibitors, and forgetting about levodopa, carbidopa, because they're worried about the levodopa-induced dyskinesia. But we need to categorize patients. What is their profession? For example, you have a professor in a university or a higher rank position. And as we know, dopamine agonists are good, but the side effect profile is very high. And usually the quality of life, the improvement, we see more with the levodopa, carbidopa compared to the dopamine agonist. So actually what I do with my patients in the young PD, from further experience, usually when we start them with the dopamine agonist, they come back with the side effect profile and there's no benefit. So when you use levodopa, carbidopa and on like low doses, and then you can add dopamine agonist with a combination, I think that's the best way to improve the quality of life and lessen the side effect profile, the dyskinesia and etc. Plus, of course, exercise, especially bicycling, it's an awesome thing to do.
Thank you very much. Christian, would you like to make any further comments?
Thank you. No, together I agree.
Thank you. So I think, Dr. Mehta, do you have any further comments? Otherwise, I'll thank the panel.
I'm learning, actually. Thank you very much.
You're very kind and very modest. May I thank, I know probably Dr. Mehta and Faiza will do the concluding comments. May I thank the panel for their time and patience and exceptional wisdom and knowledge to share with us, and particularly for people with Parkinson's, and also the patients panel, people like Jeff Chapman, who said some words which would rhyme with many of us, both from a researcher and clinical care perspective, but also from a person with, from people with Parkinson. That's the issue around hope and how important it is that we keep that going, and that should underpin all our developments and efforts to make research really feasible, tangible, and applicable to the lives of people who we care. So thank you again, the panel, for those fantastic contributions today. I'll pass you on to Faiza and to Dr. Mehta.
I truly agree with you, Professor. What I would like to say is I would like to thank each and everyone in the expert panel who has been with us for straight 3 hours. I mean, seriously, I don't know. I have no words to thank you. Same goes for the patients and their caregivers who have been with us even after all this time. We have almost 170 patients with us. And the questions were, of course, lots and lots, but we had to, of course, cut them down. Before we conclude anything, there is one, I would like to show some faces of Parkinson's, voices of Parkinson's And it's a video clip that I'm sure is going to be very dear or very close to all the hearts. الأخ عبد المنعم تقدر لو ما عليك أمر تشغلنا الفيديو.
Hello, I'm Ray Chowdhury from King's College Hospital here in London. It is from this city that the great Dr. James Parkinson described the condition we now call Parkinson's disease. But 204 years later, little did he realize that over 1 in 50 of us who grow to the ages of 75 or 80 will go on to develop this condition. Although the condition remains progressive, now we know that we can very effectively treat the motor as well as the non-motor part of this condition. And I'm hopeful on this World Parkinson's Day, very soon we'll be able to effect fantastically effective treatment for not just the motor, but also the non-motor aspects of this condition, so as to make the lives of millions of people living with this condition a lot better. Thank you.
This is a message from
Karina Shankar
and Jeff Chapman
from Melbourne, Australia.
To all our friends and friends of Parkinson's throughout the world, but particularly in the Middle East.
Let's unite for Parkinson's.
Don't let Parkinson's stop us.
This is a message from
Community.
and Shita Reddy from India to all the Parkinson's patients around the world. Let's stand united and don't let Parkinson's stop us. Thank you, Parkinson's UAE.
My name is Amna Rashman. I'm a Parkinson's disease nurse and teacher on Medical University of Gdańsk. On 11th April, we will celebrate World Parkinson's Day. The goal of my everyday work is to increase awareness of the disease, to support patients and their families, and to increase tolerance in the society. I believe that one day, due to these all studies that are carried out in the world, soon we will be able to treat Parkinson's disease, and not only its symptoms. We will fight for it.
Eu sou do Brasil, eu tenho Parkinson. Vamos nos unir pelo Parkinson. Não deixe o Parkinson nos impedir, nos parar.
Hi, I'm Alex Rizos, Research Manager at King's College Hospital, Parkinson's Foundation Centre of Excellence in London, and I'm delighted to celebrate the World Parkinson's Day with all patients and researchers. Here at King's, we aim to empower patients to play a key role in defining and developing people-based research, and we hope that the Parkinson's Day as a global event will help to highlight the importance of patient engagement in research and making research a success. Let's unite against Parkinson's and let Parkinson's not stop us.
I'm Amal from Dubai. My message is to all our friends of Parkinson's, including my mom. Let's unite for Parkinson's. Stay strong, live with love and hope, and don't let Parkinson's stop us.
Hello, I'm Yunus from the Netherlands. As a carer of my father, who has Parkinson's, on World Parkinson's Day, I just would like to say, let's all unite for Parkinson's. Thank you.
On behalf of Parkinson's UAE, my message to all is, don't let Parkinson's stop you. Let's unite for Parkinson's.
This, we come to the end of the discussion with the expert panel. I would like to thank each and every one of you in the expert panel, and thank you for your time. Thank you that you were with us. We will now continue to have the session with a local session for patient interactions. So if the expert panel would like to leave, I think Dr. Vinod can share a few thoughts before we sign off.
Thank you. Dr. Vinod.
Thank you, Professor for chairing today's session. Actually, I am honestly so grateful to
Dr. Mehta, would you try to speak a bit louder? We can't hear you. Now it's better. I heard.
Thank you. Thank you, Professor. That's very kind of Zephyr for asking me to do a closing remarks. So it's great. I'm eternally grateful to you and Per, Christian, Rupam, Dr. Michal, all the world experts on one stage. And I just want to thank especially the patient panel. I can see that Jeff and Professor Ravi Kumar and Parkinson's patient from Saudi, they have kindly agreed. It's their thoughts, actually. It's not, when they ask that they are trying to get hold of you. Say, for example, one patient from Romania was trying to get hold of Christian and few from Netherlands. So it's an idea generated from the patients. They all want to unite together, and they all, and it's a great, I have to say that it's heart touching to see 250 patients from across India, across Brazil, they're all here today. Still 184 still mining. I can see that from the organizers, I can say that there are like 36 questions still left. So it's a really honor to be sharing with you, Professor Chaudhary, Per, Christian, Rupam, and Dr. Michal. Thank you, Jeff from Australia, and Professor Ravi Kumar, and all the patients across the globe. And my heartfelt thank you. Thank you for joining in today. And also have to say thank you for the Kings and Avi for the kind support this evening. Thank you.
Thank you very much. Thank you for that.
One line from everyone to commemorate the World Parkinson's Day. To start with the chair. One line, please.
Thank you, Vinod, for dropping that one. One line would be, as has been said by everybody, but Parkinson is with us, will be with us, but it will not allow us to stop developing treatment and one day curing it.
Thank you.
Maybe I ask to Professor Odin next.
Thank you all. It has been fantastic hours together. I have learned a lot, and it has been a very well organized and nice meeting. It was a pleasure to be there.
Christian?
I just would like to echo, excellent meeting, excellent initiative. Congratulations. And I put this patient voice, empowering patients. I learned many, many things. Congratulations again for this initiative. Keep going. Thank you very much to all of you.
Professor Dr. Michal, please.
Yes, so thanks for the invitation, for this marvelous invitation. And what I can conclude here is that, like, with optimism, we will defeat Parkinson's disease. Thank you.
So, Rupam.
I would also like to add my thanks, Ray, to all that you have contributed, and each one of us has contributed. And I have learned so much, as Vinod said, from all the discussions we had. Thank you very much, Ray. And
You're welcome. Here's to working together.
Thank you.
Thank you so much. I would thank you to all the experts panel for joining us. Thank you for your time. We will
Thank you very much.
Thank you. Thank you,
We wish you all the success. Thank you.
Thank you so much. Before we conclude, one last message to the whole expert panel. I invite the whole expert panel to come and visit us in Dubai, United Arab Emirates. This is on behalf of Friends of Parkinson's UAE. You're most welcome to come and visit us. And I'm looking forward to meeting you all here in Dubai.
It's a fantastic offer, and I'm sure we can put up a nice joint meeting together as well in a similar form, but more in a face-to-face format. And I think it'll be rewarding for not just the people with Parkinson's, but also for ourselves. So, as Per said.
With kind support from Jeff Chapman and Professor Ravi Kumar as well.
Thank you.
Thank you very much.
Thank you. Thank you.
Delighted.
Now continue with the, thank you so much. Thanks a lot. Thanks a lot.
Thank you.
Bye-bye.
Bye.
Thank you.
Start video. Yeah. Sharing the screen now. Need to share the screen. Just a quick run through to still there are a lot of doctors, GPs and patients asking us how to actually not to miss the diagnosis and what is quality of life. So I just want to give you a quick run through, because this is a special request from patients, patient panel, and also some of the doctors asking a small thank you to the patients, what is quality of life, and how to diagnose. There are lots of questions we're not able to take today, because I can see that I received 31 questions still pending, asking about what is the best treatment, what treatment to choose, and what other common question is, what stage is my Parkinson's doctor? Quality of life, my dad's quality of life is not as great. So just what is quality of life, and why is it so relevant? You heard Mr. Wazefa was telling that, I documented that I'm a 29-year-old man, or as all of my life I was full of Superman energy, started with stiffness in the right shoulder, clawing toes, painful cramping. You can see there is a delay in diagnosis of his condition. After the diagnosis, you can clearly see what he was saying was, it's not the stiffness, Dr. Mehta, it's not the tremor, Dr. Mehta, that bothered me, it's the fatigue. And he'd been misdiagnosed, been sent him to orthopedic doctors, pain specialists, and a lot of, by the time the diagnosis came to him, it was already 2 years delayed. So as all the expert panels kindly mentioned, James Parkinson's diagnosed, named the condition 200 years ago. And he also 200 years back, he described about fatigue, pain, sleep dysfunction, constipation, sexual problems in his book on shaking palsy 200 years ago. So the wrong concept here, still echoing to many one, is Parkinson's is just a dopamine problem. It's not actually. The new research, a new concept of Parkinson's is not just a dopamine, contrast to the old myth. It's the other neurochemicals called noradrenaline, serotonin, acetylcholine also plays a prominent role. So as this one of our collaborative work we've done in collaboration with Imperial College while doing my PhD many years ago, we showed that fatigue, especially in Parkinson's, not just in the area of Parkinson's brain, it's actually outside the areas of the brain of Parkinson's. Not only patients with advanced disease can get fatigue, even the young patients can have problems with fatigue. So if you have a problems with the dopamine, you have a movement problem, if you have a problem with choline, memory problems, and falls with noradrenaline. So how to stage Parkinson's is number one. If you have a slight shaking on one side, then stage one. If you have problem with one hand and one leg, it's 1.5. It's just like basically for you clinicians to stage and age your condition. So the most hidden face is underrated, undertreated, underdiagnosed is non-motor symptoms. And I am very absolutely delighted and proud to share you that first time in history of movement disorders, first time in history of Parkinson's, a textbook with 2 volumes with 56 chapters, which incorporates every non-motor symptom. I'm actually delighted to be the one of the author in that prodigious venture. So what is quality of life? So quality of life is how you define quality of life. Let me tell you, there's a study of 265 patients with Parkinson's in the United Kingdom. Again, the study by King's College Hospital, London, where they've been asked to rank first 3 symptoms, most worrying 3 symptoms. If you can clearly see here, patients with early Parkinson's problem with tremor, stiffness, whereas the patients with advanced, they were more worried about the drooling, fatigue, more of a non-motor burden rather than any other motor burden. So for this to diagnose, we have a tool now called Manage PD. So let's have a quick scroll through about Manage PD. I'll just quickly run there, I don't have a time. So how to manage? So this is a tool, very easy tool to diagnose for a clinician. Say, for example, if you go to your GP or if your GP is seeing anyone. So this is a quick tool which you can get it online. Thanks to AbbVie for this thing. So we normally, as a clinicians, as a neurologist, as a Parkinson's specialist, we see 3 categories of patients. Number 1, patients may not be controlled on current treatment regime, or patients already controlled, they just need some optimization. And third category is patients are waiting for device-aided therapies. In other words, patients not getting better on oral medicines, not getting better on optimizing, long-term optimization. So the Manage PD is an instrument designed to support healthcare providers like GPs, family physicians, who are asking us how to diagnose early the Parkinson's, how to refer to a Parkinson's specialist. So say, for example, so it's a very easy tool. It's a self-rated questionnaire. Say, for example, this incorporates 5 questions. How many daily doses of levodopa? Does the patient report taking 0 to 2, 3? How many hours of total off periods means stiffness? And if it is unpredictable or predictable and experiencing like anything problem with activities of daily living, then the scoring comes in. Say, for example, if your patient taking levodopa more than 5 times, and if your patient reports to you that it's getting 2 hours stiffness on half unpredictable fluctuations and limitations in daily living, then if answer is yes to any of these questions, you can have another section 2, which can help you to validate objectively to refer the patient. Say, for example, how often your motor fluctuations are, how troublesome your motor fluctuations are, easy, mild, moderate, or severe. And especially, this is very important bit, is troublesome off periods. Some patients can get this freezing, intermittent freezing, that should be fine. But if it is prolonged dystonic freezing or dystonic pain and dyskinesias, then we can have this. This will be very useful to quantify that dyskinesias and your freezing time. And also the dystonic pain. We get a lot of patients complaining of severe pain. And we have a Parkinson's pain scale at King's by, again, Ray being a lead pioneer of this one. We have a validated tool to score the pain as well. So, and the last but not least, activities of daily living. This actually impairs the quality of life, and quality of life directly or indirectly can address the quality of life. So falls, again, there's a, whether the falls are frequent, infrequent, and especially the non-motor off symptoms, which is challenging to most of the Parkinson's specialists, even for specialists like us, very difficult to quantify, validate the non-motor offs. And how often is the patient experiencing impulse control disorder? Especially this applies to a lot of patients who are actually on dopamine agonists. So I can clearly see, practicing for many years, that either patient on pramipexole or ropinirole, especially this D3 priming is the one which can cause impulse control disorders like punding, dopamine dysregulation, hypersexuality, etc., can be a huge burden to the carer, and causing carer burden also. How often, there's another question on hallucinations. Again, this sometimes we do see this, especially with the dopamine agonists. especially ropinirole, can cause these type of excessive daytime sleepiness, hallucinations, and psychosis. So how to score? Very easy, like any other validated scores, like frequency scoring 1, if it is rare, 1, frequent 2, most all the time 3, then severity score mild, moderate, severe, and falls per month, level of activities of daily living. So this is a simple algorithm which you need to follow. That say, for example, if the patient has to have to take more than 3 times or 4 times of levodopa, it comes under category 3, less than 2 or 3, category 2. So again, this is one of the non-motor symptoms questionnaire now being validated in 56 countries in 56 languages. So a small vignette of a patient I'll run past through. This gentleman with lots of cocktail of dopaminergic drugs, we can see that he's taking 18 points of levodopa, combination of ropinirole, anticholinergics, uncontrolled release, 19 tablets. So what's the next? You can, based using on this validated PD, valid managed PD tool, you can clearly see comes under category 3. Then this type of patients needs to be referred for device-aided therapies. Again, in England, we follow a strict NICE guidelines or what is. So there's a question, $1 million question for most of us. What is the best? Is it apomorphine pump, or is it the surgery, or is it intrajejunal levodopa infusion? So what we do is we follow a traffic light model. Sorry for the interruption. We follow traffic light model. Say, for example, if you can see here, if all the reds, a patient over 70 with comorbidities, falls, psychosis, impulse control disorders, sleepiness, cognitive problems, the evidence is against the deep brain surgery. So we can see the most greens and amber, or we can choose the patient based on this traffic light model. I personal experience, as discussed with expert panel, if a young patient with unilateral refractory tremors, I personally refer them for DBS, whereas the patient not responding very well to agonist and maybe the apomorphine, whereas patients excellent responded to levodopa, not able to tolerate agonist, like other patients with hallucinations, psychosis, impulse control disorders. Intrajejunal levodopa infusion is the treatment of choice. So on this note, I would like to conclude that so device-aided therapies are the ones where we need to consider without any delay if you based on a managed PD tool. So thank you very much. Thank you very much. Tell us. See, Muhammad, don't worry. See.
في النهاية نشكركم على حضوركم، ونشكر الداعمين على تواجدهم ودعمهم لإنجاح هذا المؤتمر. مشكورين، يعطيكم العافية، وإن شاء الله نشوفكم في المرات الجاية والجاية إن شاء الله. مشكورين، الله يحفظكم. وفي هذه الساعة نكون وصلنا لختام هذا المؤتمر. أتمنى أنكم حصلتوا الاستفادة، وحياكم الله. وما زلنا إن شاء الله في الأيام القادمة مستمرين إن شاء الله معاكم بأشياء إن شاء الله كثيرة. مشكورين، الله يحفظكم جميعا.